Yes. On peut commencer directement?
Attends, setting up.
Ok, non, ok. Mais quand ça fait sur YouTube, est-ce que ça va faire un écho? Non? Oh, okay. Cool. So start the webinar now then. Oh. Cool. So start the webinar now. Wait a second. Faut que tu fermes celui de YouTube, non? Ou tu coupes le son? Ouais. Ok, vas-y. Okay, so we already got 10 participants. I have 4 attendees. Okay, so good evening, everyone. So we're going to be making a start in about 2 minutes. So I welcome you all. First of all, thank you so much for being here tonight. I really appreciate it. And so we have Fime going on first. So let me check Fime. Oh, you're here. That's it. Okay, so I'll do a quick intro and we make a start with Fime. Ahmed. So first of all, good evening, everyone. I would like to welcome you all for the very first Pharmacy Social Prescribing Conference globally. So we have a lineup of 15 exceptional speakers for tonight, and I'm so thankful for the support for the event. And so a bit of background, what was PASS, the Social Prescribing Pharmacy Association, was set up in order to fast-track social prescribing adoption in pharmacies in UK, potentially globally. And my background about myself, I'm a UK pharmacist, but I'm also a dance for Parkinson practitioner, which led me to eventually find out about the topic of social prescribing, which has become a life purpose for me to embrace social prescribing and to send my message to everyone in the title of evangelist. And just a reminder that at the end of the conference, there'll be a networking lounge. So just above my head, there's a link for you to register. So after the conference, it'll be an informal session for you to sit down and then just network with speakers and other delegates. And without further ado, I would like to present you all Fahim Ahmed from MedLearn. So yeah, go for it, Fahim.
Thank you very much. Wow, this is an absolute amazing opportunity to be here today. So for those of you who don't know me, my name is Fahim. It's a pleasure to absolutely be here. And this conversation that we're having today has absolutely changed everything that I do as a clinician and our vision at MedLearn. So I want to start off by thanking everyone for being here, from Arun to Michael to everyone who's here today. Is fantastic for you all folks to be here, because ultimately what we're giving here today is our time, which is the most precious thing that we have. So brilliant for everyone to be here today. And Arun, you have absolutely changed my perception on things. And I'll tell you why. So I have this vision, right, that every single person in this world has access to healthcare that is delivered by clinicians that wake up inspired. And you go home and you're fulfilled by what you do, which is what I do, which is what I love. But today we are about to make a change to that vision. And what we're going to do is we're going to knock off the clinician, and we are now going to write here people. Because I have realized after today's conversation that I'm about to have, that there is more to health and well-being than what clinicians have to offer, whether it's a doctor, whether it's a pharmacist, whether it's a nurse. And this is why, for me, this is an absolute landmark opportunity, because Arun, you have absolutely changed the way I see health and well-being. So thank you very much for this, because our vision at MedLearn has just officially been changed as a result of the conversation that we've had. And I just want to put it out there that we're going to change this. We're not talking about clinicians. We are talking about people who can actually make a huge difference to people's health. And let me just explain this a bit more. Let me just really get into this, folks. So my plan in these 50 minutes is to define what is social prescribing and really make that clear for everyone today, but also to relate traditional prescribing to what is actually possible. And this is what we're about to do today. So we're going to get right into this in a moment. I'm just going to make sure that everyone can absolutely hear this. So here we go. Let's talk about the definition. Now, I'll be very honest with you. When Aaron approached me about social prescribing, I didn't have a clue. I remember he rang me up and he said, Fahim, would you be interested in having a conversation on social prescribing? I thought, what is social prescribing? What does that have to do with anything that I'm doing? And he said, don't worry, I know you can do this. Just talk for me on the day. I said, okay, I'll do it. So I started to research and I thought, what is social prescribing? So being me, I had to do research and do some due diligence, and I broke down the terms. I mean, there's various definitions out there, folks. I mean, you can go onto the NHS website and you can see all sorts. I mean, this is an example of a definition. And the reality is, I don't know what you think about it, but things aren't that clear. I find it a bit unclear or a bit wishy-washy. That was my thoughts on it. So I said, let me break it down for everyone today. And with my students that I'm teaching, and I asked them all, what is social prescribing? Out of those, 800 students, most of them said, don't know. What is social prescribing? Why is that relevant? So today, we're going to break it down. Let's look at this. Let's break down the terms. First of all, social. Let's break it down. So social itself has all to do with people, has all to do with communities, organization. It's all to do with people and communities and organizations. So just bear with me, folks. Bear with me. That's what social is. When we're talking about prescribing, traditionally, you might have felt actually prescribing is all about medicines, right? This is what I thought. When he approached me as a clinician, I thought, what's social prescribing? You're not prescribing medication. You're not prescribing any sort of treatment. Why does this have anything to do with healthcare? If someone's unwell, prescribe them a medicine, next. If you've got a pneumonia, prescribe them medicine, next. If you're feeling lonely, prescribe them a medicine, next. We can do that. We can have this, we can have this kind of, treat the symptoms approach, and we can do that. Treat the symptoms approach. But then I thought, wait a second, he's got a point. When I started to look into social prescribing, I realized that there's more to our health than there is more to what makes us unwell than what meets the eye. So let me give you an example, right? Let me give you an example. Imagine we have patient A, and let's really break this down for you folks. So I want you to keep this at the back of your mind about treating the symptoms. And I want to give you all folks a scenario. And I want you all to get involved in this. We want to make this fun. We want to make this interactive. And I want you to tell me, if you have a patient and this patient presents to your clinic and says to you, I am feeling low. Tell me, anyone on the chat today, and we've got a very short time, so Alex or Catalin or Caroline or Claire, whoever is here today, tell me, how would you approach this case? Very basically, if I presented to you right now as a clinician, or as a patient, and I said, I'm feeling low, and I told you I'm feeling depressed, tell me one option that you can do. And I've got a very short time, so I've got 10 minutes left, so please do engage. Write it on there, folks. We want to make this engaging. We want to get to know each other. So please write it on the chat. How would you approach this? Tell me what you would do. Helen, Jack, Jane, I know you people are shy. You don't need to be shy. Kiran, Leona, put it on there. I'm asking you a question that if I presented to your clinic, even any of the panelists, if I presented to your clinic right now and I said, I'm feeling low, which one way could you approach this conversation? Okay, so Alison is absolutely, I love this. Alison has gone down the route of refer to local community sports or music groups, choir, good. So that's one way of doing it. So that's one option. Who else wants to approach this? Leona, Lisa, Monica? Ask what matters to them, fantastic. So someone's put ask them open questions, good. Consider using a screening tool to assess severity. Ask them what they want, right. So we're all on the same tracks. Let me explain one of the ways that I would have approached this before this conversation. I would have looked at the symptoms and said, right, you're feeling low. That's the symptom. So I am going to address this. Let's address this issue. So you're feeling low, let's address this issue. So what I would have done, I would have said, okay, you're feeling low. Why don't we address the symptom? So I would just with keeping it very basic. So without going into risk assessment, just let's step back a bit. Let's make it a bit broader. What I would have done was, okay, for example, you could approach it two ways. You could say, right, you're feeling low. This is the problem that you're having. Let's treat the symptoms. So option number one would be, let's treat the symptoms. So we treat the symptoms and we prescribe them a medication or whatever it might be. Another way might be where you say, right, let's start to find out why you're feeling low. Let's actually try to solve the problem. Let's try to solve the problem. So another way that we could do this is let's solve the problem. Rather than treating the symptom, I'm going to approach it laterally from a different angle. So we're going to come up with some different funky ideas. And I'm going to say, why are you feeling low? And you know what this patient tells you? This patient tells you that the reason I'm feeling low is because my wife has been diagnosed with dementia, and I am the only carer. I'm stressed out. I'm looking after her 7 days a week. I'm all alone. I'm depressed. Can you help me? He necessarily does not need an antidepressant. He needs a holistic approach to his health. He needs a team that can support him with the problem that he's having. And all of a sudden, he does not need the antidepressant. I'm going to say that again. And I want you to really focus on this. If you've got your phones, switch your phones off. Just listen to this. We've got a patient who presents to your clinic and he's feeling low. You could either, number one, address the symptoms and say, right, you're feeling low. And I'm putting this very crudely. So please, we're making it very simplified. Obviously, there's more to it. Yes, we would do a risk assessment. We know all that. But let's step out a bit and let's look at a person as an individual. Let's put the academic stuff aside and let's look at this person as an individual and understand that your health and well-being needs are more than just about basic, your health and well-being needs are affected by your education, by your surrounding, by your support networks, by your family, by your state of mind, everything. And essentially what we can do then is we can start to get to the root cause. Why you're feeling low isn't because you're having a chemical imbalance, or it may result to that. The reason why you're feeling low today is because you've got issues that are beyond a medicinal approach, that is beyond a traditional prescriber medication, because actually the antidepressant doesn't solve your problem. It certainly will help with the symptoms, but it won't solve the problem. This is going to escalate. The problem is that you're all alone. You're lonely. You've got no one there to support you. You need help. Let's give you that help. And let's make a real difference in your life and not just go down the route of prescribe medication and next. I hope that makes sense, because my mind has opened today. After realizing why Arun is so passionate about this, I've realized that we need to not only focus on the traditional way that we treat people's health and well-being, but open our minds up. And as a pharmacist, I've realized that there's more to a patient being unwell than simply prescribing this individual an antidepressant. And that is what I wanted to get across, because we've got a very short time and I've only got 3 minutes left. But I have come to realize that we need to look at a patient as a person and start to move away from the symptom approach and try to understand why this patient has these symptoms. Try to understand why this patient has these symptoms and address. Let's look at weight loss. Why are you eating junk food? Why are you not able to exercise and look after your nutrition? Why? Why are we prescribing you Xenical? Why are we prescribing you Orlistat? Why not consider other means? Very, very important to look at things from a different angle. And Arun, I can't thank you enough for opening my mind to the way I need to approach patients and how we can make a difference to patients' life in a separate way. And I honestly wasn't aware that GPs are actually, and this might be me being naive, but I never knew that GPs receive phone calls for patients who have housing issues, who have issues with poverty. I mean, I was speaking with one of the doctors today, and he said that I've received a call from a patient today who has been chucked out of his house because he's had an argument with his mom. He's sleeping in a car, and I received the call. And I thought, why would you call a doctor? Because they have nowhere to go. We can solve that problem. We can take burden off GPs, and we can help different patients and make a difference to patients' lives. Why? Because this is something that makes you fulfilled. Doesn't matter what money you make in the world, but when you make a difference to someone's life and you put a smile on their face, that is something that's long-term. And for myself, I'd like to just leave this message behind that we need to take a holistic approach to patients' health care, and we need to open our mind to what we have here. So Owen, thank you very much for giving me this opportunity to be here. But healthcare is more than just the simple things that we see. And if anybody has any questions, by all means, you can ask me. But for myself, Arun, that is all I have for today. And I will certainly be incorporating this in our vision at MedLearn to inspire clinicians to look at things differently. So thank you very much for giving me this opportunity. And it's fantastic to be here.
Wow. Honestly, thank you so much, Fahim, for such a powerful presentation. I mean, I'm so glad that you found social prescribing useful for your future practices at MedLearn, because I mean, I see you're very involved with the pharmacy training, especially the young generation, to think broadly on how they can become entrepreneurial, take it to the next level, not just being confined, not just being a dispensing pharmacist, isn't it? So I was already fascinated by your work. I mean, for instance, when I do training and people ask me, what do you recommend to help become a pharmacy entrepreneur? And I say, go to MedLearn. Fahim Haman is the man for you to take inspiration from. And tonight you just presented it in such a beautiful way. Honestly, inspired me so much. Thank you so much, Fahim.
Thank you. Thank you.
And so in terms of question, let's see if we got time. We got 1 minute for question. Does anyone have any question in the chat? Not at the moment. So yes, if you do have any question, feel free to reach out to Fahim directly. You can forward it to me, and I can put you in touch with our amazing presenter, Fahim. Thank you so much for tonight. So without any further ado, let's present our next speakers, being Harry Pearson and Dr. Adam Rodborn from Newcastle University, that have done such an inspiring work. Because for me, pharmacist is not just about being a pharmacist, also the future generation, such as I personally was a fourth-year pharmacy student, and also the support of his lecturer, Dr. Adam Rodborn. So I'll leave it to you, Ari, and to implement yourself. Go for it.
Get technology to work for me.
No worries.
Let's go on here. So yeah, as Aaron just kindly said, so my name's Harry. I'm currently in my final year of pharmacy at Newcastle University. And I'm going to be talking a bit about my dissertation, which was on community pharmacy views on pharmacy-led social prescribing in Newcastle. So I was supervised by my project, as Aaron said, by Dr. Adam Rathburn, who's a lecturer at the university, but he's also a senior clinical pharmacist and has conducted research projects in the field of primary care, and he's on the panel tonight. I was also supervised by Professor Gillian Rowlands, who is a general practitioner and a professor in the Population Health Sciences Institute. I just quickly want to say thank you very much to everybody who took part in my project and had interviews with me over the past couple of months, because it was a huge help, and I'm sure some of you are in the audience tonight. So thank you, guys. Now, the aim of my project was to understand the views held by community pharmacists in the Northeast on the potential for pharmacy-led social prescribing. So we put an interest form onto social media and had a number of responses from pharmacists across the region interested in our study. And these participants were then invited to take part in a single interview, which was done over Zoom, Teams, and over the telephone, which focused around gaining an understanding of their current knowledge of social prescribing processes, and also kind of any advantages and disadvantages they could see to pharmacy-led social prescribing and any barriers to its implementation that they might foresee. Now, in total, I interviewed 11 participants, and they were from a range of backgrounds in the community setting. So we had pharmacists from multiples and independents, locum pharmacists, community pharmacists in a general practice, and a pharmacy owner. So it was really important to me to make sure I had representation from as many sectors of community pharmacy as I could. Now, getting on to the results from the project. So first of all, the majority of pharmacists that I interviewed had previous awareness of social prescribing. They expressed that this knowledge was from a variety of sources. For example, some worked in locations where they were hiring social prescribing staff, and so knew about it that way. whereas others conducted research themselves and had clinical diplomas, which gave them an awareness of social prescribing. But others had heard about it through the media, so hopefully, social prescribing is getting out there, and people were hearing it on the radio and had seen news broadcasts and things about it. So that was really interesting. And actually, from everybody I spoke to, including those who didn't have a previous knowledge of social prescribing, they all showed great enthusiasm for the service and really felt it was perfect for community pharmacies to take on, and were really keen to have some form of involvement in it in the future. Now, this is just a list of the themes that were raised in the interviews that I had regarding the advantages to pharmacy-led social prescribing. So the main discussion point that came up in most of the interviews was that the accessibility of community pharmacies is its biggest asset. Participants felt like, this makes them ideal locations for engaging patients in social prescribing. And the idea that no appointment is needed to speak with a pharmacist and patients can come in and have access to that service was a real benefit. Also raised was that community pharmacists have that really solid understanding of their patients and the need of the local community that they work in. So they felt like this could be a real benefit to involving pharmacists in social prescribing, as there's often a really good relationship between patients and staff in the pharmacies, which could encourage the uptake of social prescribing this way. And then there's the added benefit that pharmacists have a wide-ranging knowledge of health conditions, and how to treat them, not only, as Fahim was saying, medically, but non-pharmacologically as well, including the fact that you're trained in communication and confidentiality and things that would really make them a great addition to social prescribing schemes. Now, participants did identify some disadvantages to pharmacy-led social prescribing. So first of all, they were concerned about the additional workload that this service might bring to community pharmacies. So they identified the fact that they're already very, very stretched, and especially over the past year, they've become even busier over the pandemic. And they were cautious about just how much time this might take up and what they'd be able to do in terms of delivering the service to its full potential. Others discussed the fact that community pharmacies are often run by locum pharmacists and don't have a regular pharmacist in all the time. They felt this could make social prescribing slightly more difficult, as without having that regular pharmacist there, they won't have necessarily as good a knowledge of the patients, and the relationship between them won't be as strong. But also importantly, with social prescribing, the knowledge of the local area and organisations that are used for it needs to be quite on point. Now, the reaction from patients was a concern for some, and they were worried about how they would go about approaching patients without damaging that relationship they have with those individuals. Although there were some contradictory points to this, which was, that participants felt pharmacists would actually be the perfect people to do this, based on the fact that they're trained in communication and consultation skills, and that this would hopefully overcome this issue. Now, I also discussed with participants what role they felt community pharmacists could take within social prescribing. So I got a number of different responses to this. And firstly, the majority felt like the identification of patients was most likely the role that they would see pharmacies taking. So this was the idea that pharmacists could find it quite straightforward to look at their patient base and be able to identify those patients that would benefit from some form of social prescribing intervention. So it's often the case patients will come in and speak to the pharmacist or the staff and confide in them with what they may be struggling with, or ask for advice on certain issues that would give the opportunity to then speak to someone about social prescribing. But then there's also the idea that you might notice a patient's dose of medication, for example, like an antidepressant going up, and that could be someone you then identify for social prescribing. Now, the roles participants discussed did range quite a lot. So some thought a signposting role would be best suited. Providing patients with the information about social prescribing, and then they themselves go and seek out that advice. But others saw the potential for pharmacists to carry out full referrals, and that they have the knowledge base and the skills in order to do this. But interestingly for me, many felt like the wider pharmacy team could have a role in social prescribing. So dispensing staff and pharmacy technicians could also take on a role. They discussed the fact that these staff members often have just as strong relationships with patients as the pharmacist does sometimes, and also, many dispensing staff will have additional qualifications and carry out health screenings themselves, and so could take on a role in social prescribing. Now, a few pharmacists also talked about delivery drivers as a means of accessing vulnerable patients. So, over the past year, pharmacies have increased their number of deliveries that they're doing, and just with the nature of this is that you're delivering to patients who are unable to access the pharmacy for whatever reason, but more often than not are those who are most vulnerable in the community. So by potentially utilising delivery staff to feed back to the pharmacists on the patients they visit and who may be struggling, you could really involve them in some form of social prescribing in that way. Now, so these are kind of the main barriers that pharmacists felt would limit social prescribing within community pharmacies. So as previously mentioned, many were concerned over the added workload and what this might look like for pharmacies to take on. So this was partly the reason why so many participants felt like slightly smaller roles, such as identifying or signposting patients for social prescribing, was kind of the limit to this role. They felt, given how busy they are, the opportunity to take on such a great referral role would be a little bit more difficult. It was also raised that training is going to be needed for the staff who are going to be involved in these social prescribing processes. So it was mentioned at the beginning, as much as quite a few people did know what social prescribing was, there's a significant number who don't, and they would need to be educated on what the service entails and what this is going to look like within social prescribing. On the training perspective, I think as healthcare is really becoming more about the holistic approach to patients' care, I think we as a profession need to be aware of what social prescribing is, and therefore, I think there's an option there to implement this and integrate it in an undergraduate level as well, or potentially even at pre-registration. And a lot of the people I spoke to also raised this. Now, a big outcome from the interviews that I had was that many felt the funding of community pharmacies would maybe need to be a little bit reviewed in order to make pharmacy-led social prescribing a viable option. So it was discussed that the focus for many pharmacies is on dispensing large numbers of items, and because there's, this is where the greatest profitability of these businesses is. And that they felt in order to encourage businesses to take on another public health service, the funding might need to reflect that. And if that happens, it would make the time spent conducting referrals more worthwhile. Now, participants also had concerns that adding another service to community pharmacies might create additional targets that the staff would have to hit. So currently pharmacies are pushed to hit certain numbers of MURs or NMS referrals. And it was mentioned that this can lead to staff being pressured to provide these services just to hit kind of quotas. And so they felt like if social prescribing is going to be implemented in community pharmacies, it needs to be ensured that referrals are done on the decision of that pharmacist, and for those patients who are really going to benefit from social prescribing. Now, I just put a slide here just summarizing some of the key implications to future practice that came from the study. So a great finding was simply down to the enthusiasm community pharmacy had for social prescribing. Everybody wanted to be involved regardless of their previous knowledge of the process, and felt like it was such a well-suited service to community pharmacies. The idea that training is going to be needed was a big talking point, and many discussed the fact they think a number of their own colleagues might not fully be aware of social prescribing and the benefits it can have for their patients. Another thing that was raised was, the services would be great attributes to community pharmacies, but the time available to fully partake in this without it being slightly a reduced or limited role needs to be addressed, and maybe methods to free up pharmacist time to carry out this service would be needed. So looking at things like accuracy checkers and things like that. And again, I think that with a funding model that would reflect a more patient-first, service-driven approach, social prescribing could really be easily implemented in community pharmacies and would really widen the reach that social prescribing currently has. So that is my project in a nutshell. Thank you all for listening anyway. And Aaron, thank you so much for inviting me along tonight. It's a real pleasure to be here. So thank you for that.
All I can say is just wow. Honestly, Ari, you've done such phenomenal work. I mean, me being involved in leadership for the dance community for the past 10 years, sometimes you can feel a positive energy coming from other person, and you have such a powerful persona, and then you definitely have leadership quality, inspire other people to say, you know what, how you inspired me, let me get on with the social prescribing movement. So hats off to you for the phenomenal work you've done. You inspired me. I'm pretty sure for delegate watching here tonight, you inspired them as well. So honestly, thank you for providing such a groundbreaking work for future community pharmacists to follow your step and potentially take it forward. For example, as a PhD project or working with the government. So honestly, thank you so much, Ari.
Thank you so much, Aaron. Thank you.
So I would like to leave it to the floor to ask questions. So Dr. Adam Radburn will be talking on behalf of Ari to answer any question that any delegate attending tonight may have. So let's see who we have as participant. So we have, for example, Eileen, Stephanie. Feel free to jump in to ask a question.
While we're waiting for some questions to come in, I can just kind of talk a little bit more about what the project kind of looked like and what the impact of it, what we're hoping to do next with it. If that's all right. So it was a qualitative project, so it took an in detail look at what pharmacists think. So most pharmacists tend to be familiar with kind of randomized control trials and big statistical studies, and this wasn't one of those. This was a deep and meaningful study trying to understand what it was like for community pharmacists to think about social prescribing in their everyday practice. And you might have seen other publications recently, in the PJ, that looked at generally what pharmacists felt about social prescribing. This study kind of adds to that and complements that by giving that rich, detailed understanding about what influences their daily practices that maybe those big survey studies maybe doesn't capture. So what we're hoping to do next is basically show this work to policymakers, decision makers about where the money gets allocated for pharmacy remuneration, people at the PSNC, people like that, so that they're aware that this is something that pharmacists feel they can do. They've got the capability, but they just need to make sure that they're remunerated properly so that the workforce is there to be able to do it. And part of what Harry mentioned is one of the key things he found was that people want to see the evidence of social prescribing. They want to see what the evidence is. And this work provides some of that evidence that pharmacists can do social prescribing, that they're able to do it and contribute to that important effort. So there's a question come in from Nira. So I'll just have a quick read of that. So what are some of the additional skills required for social prescribing, additionally to or building on the skills currently being taught at university or during pre-reg? How do you envision this being taught? So I think that's a great question, Nira. I think with all new services, we have to think about how we're going to teach people. Obviously with COVID, a lot of what we do now teaching wise is online and virtually. And I think this is the type of service where really we're still figuring out how to train people to be able to make those referrals and signpost. In the NHS long-term plan, the plan talks about having link workers and CCGs employing link workers who will be able to make referrals to different social prescribing initiatives. And at the minute, those people are still being recruited and still being employed. There are some in post already. I think there's 2 that are linked to pharmacies. If I'm sure I'll be corrected if I'm wrong, but I think there's 2 that are linked to pharmacies. The rest are kind of based in PCNs or CCGs. So looking at how those people have been recruited to post, what they've experienced in their initial couple of weeks in practice will help us then learn what we need to teach people who are going to go into those roles, either in pharmacies or in CCGs. So we're still figuring out what those skills are that people are going to need and how we're going to actually upskill people. I think, like Harry said, having something at undergraduate level is probably going to be required so that people are aware of the social determinants of health and public health initiatives in their area, but also the local aspects of what's available. I think that maybe won't fit into an undergraduate curriculum. It will have to be something that's done maybe as a foundation training, or maybe even as a local training once you get into post, as a top-up mandatory training type thing. So yeah, that's kind of how I envisage that being taught. Harry, do you want to add anything to that? Do you have any skills or think if there's any skills particularly that people would need to do this?
I'm not too sure. I think from my view of an undergraduate level, it was kind of speaking to my colleagues at university and seeing what they know. And, when we were all doing our dissertations, nobody kind of knew what mine was about, and no one was really aware of social prescribing. And so I was kind of that friend trying to tell everybody about it and make sure people knew what it was and get it out there. I think there's another question which Adam's kind of touched on, which is how common is this in community pharmacies in England? Adam just mentioned there's only a couple that I think we're aware of which currently do it in post, but even through my project, I did a bit of a literature search and I think it was only about 7 articles or papers came up linking social prescribing with pharmacy. And so I think there's definite space there to do more research and hopefully get some more stuff put out there.
Yeah, I'd agree with that completely, Harry. So we did a systematic review as well, and that only identified 6 studies or 7 studies that actually could show where a pharmacist was involved in social prescribing. And just like Harry mentioned, that there was different ways pharmacists could be involved, either as people identifying the patients for referral, people making the referral, or people actually delivering the service themselves. The the evidence for those roles isn't really there in England at the minute. So I think that's across the board in other places as well. I don't think there's a huge amount of evidence to say how widely this has been rolled out and in what capacity pharmacists have been involved in it.
So thank you very much for the very good question. We're just running short of time due to a very tight schedule, but please do send me the question afterward, which I can pass on to Dr. Adam and Aaron Pearson. So thank you so much for providing a very powerful question. So now, next up, we have Mr. Michael Holden, one of my people I look up to. He's been heavily involved with the Healthy Living Pharmacy scheme. I met him for the first time in 2017, and he was also kind enough to provide me a book testimony for the book I've written on pharmacy social prescribing. So without any further ado, let's welcome Michael Holden to the presentation. Thank you, Ari, and thank you, Dr. Adam.
Evening, everybody, and thank you, Adam. Hopefully you can see the right screen. I've got several screens in front of me, so hopefully you're seeing the right screen now, because I can't see what you're seeing. So, can somebody give me a nod? Aaron, can you see the right screen? Great.
Yeah.
Okay. Thank you. So, yes, social prescribing and health living pharmacy. And firstly, just like to say thank you for Aaron for the invitation to come and join the SPPA event. And an opportunity to join you at this inaugural conference. Really want to share with you, and maybe you don't have a big understanding of healthy living pharmacy, but how that synergizes extremely well with social prescribing. So just a little bit of background first before we get into that. Why did we invent, or why did we create and conceive the concept of healthy living pharmacy? Back in 2009 in Portsmouth, where we started it, was when local commissioners of health and public health were looking for solutions to improve the health and well-being of their population and reduce health inequalities, which we know from people like Sir Michael Marmot were bad 10 years ago. They're not any better now, but they were bad 10 years ago. So let's try and do something about it. They also identified at that time that pharmacies varied in terms of their uptake of services and delivery of services, not only in quality, but in consistency. And we're looking for more people to do more and more often, basically. Some of that variance, that sporadic nature of delivery was down to all sorts of things, but some of it was down to trust and relationships. But a lot of it was around not having a shared vision. I'll call this the why, and an understanding of what needed to be put in place to deliver that, the how, and therefore what the benefits were from doing something different, the what. We also wanted a brand, which was the public would relate to for all pharmacies, not a brand of an individual pharmacy, but a brand of pharmacy, but said that they're more than a supplier of medicines, one where advice and support on the range of health and wellbeing matters can be accessed in the front line of the NHS. It was conceived at a time when the pharmacy white paper, Building on Strengths, Delivery of the Future, came out in 2008. And that was probably the last real vision that we've seen for community pharmacy until recently. And that call for an expanded role of pharmacy in healthcare, and something many of us continue to call for at this stage. So what is a healthy living pharmacy? Well, it does what it says on the can, but there's so much more to that underpins and enables it to work with the integrated health and care systems. Some of this is about organizational development and change management within pharmacy. That's very business management speak, and not necessarily what everybody in pharmacy wanted to hear at the time, and in many cases still does not. But the fact is, change is necessary for all sorts of reasons, which we're not going to go into tonight. Hence the brand and the vision that went with it. And that was illustrated through a passionate narrative, which I continue to, and many other people continue to voice, but also the establishment of evidence that demonstrated that it makes a positive difference for the public, to communities, to commissioners, and to community pharmacy itself when it's done properly. As I already mentioned, commissioners were asking for a greater consistency in the quality and delivery of services across a wider range of pharmacies. They also wanted to leverage the enormous footfall and pharmacy has, with almost 500 million visits a year in England alone, to discuss health conditions. That's at least 4 times the number of accessing any other healthcare professional. The aim was and still is to improve the health and well-being of their communities and reduce health inequalities by converting more of these significant number of interactions into intervention opportunities. Some of you will know this as MEC, make every contact count, and such things as healthy conversation skills. And this principle can easily be applied to social prescribing and the skills that go with it, of course. This is achieved through many things, but including health promotion, health protection, and brief interventions to prevent ill health, but also under the MEC umbrella as healthy conversation. Early on, we recognized that this required new skills and knowledge, including leadership to make it happen, and an understanding of why, when, and how to utilize those skills. Professional environments that are health promoting, utilizing digital technology and media channels, and events to give the messages out to the community. Also access to information, signposting, and preferably referrals, providing pathways have been set up. A wider range of commission services, a more holistic approach to patient consultations. This is where it really starts to gel and synergize with social prescribing, that holistic style, a holistic approach to patient needs. These are much more about understanding their needs and their priorities, not our needs and priorities, but their needs and priorities, both physical, mental, and social, rather than just about their medicines. This is something that Fahim touched on earlier, and that light bulb moment he's had. Although we must not underestimate the importance of looking after their medicines and their health from that perspective too. Increased engagement with both the community and other healthcare professional providers are a key element of Healthy Living Pharmacy. But ultimately, Healthy Living Pharmacy is about the pharmacy team, the ethos they consistently live and breathe, and how they connect with people in their community. In the early days of establishing Healthy Living Pharmacy as a model, people from ministers downwards used to ask us to go and see it. And I used to say, don't go and see it, go and listen to it, go and feel it. It feels different. The experience and experience that ethos, which is very different in terms of how it interacts with the public. So let me just start now to explore those synergies in a little bit more detail. The former is an increasingly establishing itself within primary care networks, as we've heard already. The latter is now established as a requirement for all community pharmacies in England. It's important to understand what social prescribing is, and we've had an illustration of that already. Focuses very much on the individual and what matters to them, and involves referral to someone who can help them, the individual, depending on their identified needs. Healthy Living Pharmacy is about a broad range of brief health interventions and may include a delivery of support services such as sexual health, stop smoking, healthy diet or weight, or alcohol or other substance misuse interventions. But it may still require referral to someone else with the capacity and capability to support that individual. Both are person-centered, take a holistic approach rather than a narrow clinical approach, and are focusing on improving a person's health and well-being by preventing ill health and reducing those health inequalities. That leaves a question for the NHS commissioners, primary care networks, and for pharmacy itself. Given that the NHS plan and the latest health and care white paper recently launched are all about the integration of patient-centered out-of-hospital care, why not integrate the two and have formal referral to a social prescribing link worker from a pharmacy within a commission service? There's also an opportunity to commission social prescribing from community pharmacy itself as part of an integrated primary care service. This is not just about competing, it's about completing for the benefit of the population. Here's a quote from the journalist Norman Cousins, which I'll leave you to read. And I'll finish for now with this question for you to consider. Perhaps in addition to qualified health champions, which we already have in Healthy Living Pharmacies, many of them, we would also like to train social champions in pharmacies. So, very brief run through, and I'd prefer to spend the time listening to you and starting to take some questions.
Thank you so much, Michael, for this powerful presentation. I mean, it really means a lot for you being here tonight. And so, yeah, any delegate, if you got any question, put in a chat box, and then Michael can answer it with you. You got about roughly another 3 minutes or so for question if needed. So let's see if any question comes up. Kathleen, describe a link worker. Any question? Anyone?
I mean, if I can be proactive on this, Aaron, earlier on, both Harry and Adam referred to the skills in response to a question to the audience. And those skills are really important. And that's, if you remember when we were talking about health and living pharmacy, we established the level of skills that were required across the pharmacy team and put those in place as part of the specification. And I think that review needs to be done now. But if we've got social prescribing link workers, they're getting trained. We have social champions out there already in communities and in organizations. So let's learn from that. Let's not reinvent the wheel. Let's learn from that and bring it in to pharmacy and make it work there, because it's not that hard. You know, a good consultation, whether it's about their social needs, their mental health needs, or their physical health needs, or their medicines, is no different. So if we can get that right, then we can deliver against this agenda.
Definitely. Thank you, Michael. There's a question from Stephen Slane asking,
hello, Stephen.
Saying, is there a value to integration?
So value to integration, I suppose I can flip that on its head, Stephen, and say, what happens if we don't? Because if we don't, the risk is that somebody else does what we could do. And actually, the sum of the parts is far greater if they're brought together rather than in a silo. I know it's challenging, and I know the contractual arrangements don't always lend itself to it, and certainly historical baggage gets in the way of it sometimes. But the agenda out there from governments, whether you're in Northern Ireland like Stephen, or Scotland or Wales or England or anywhere in the world, integration by a name or other is on the agenda, because that gives value for money for the taxpayer and the health system, but it also gives a better outcome for the patient or the person.
Thank you, Michael. Any more questions from the floor? Participant. It can be anyone. So for example, there is like Joey, Kieran. Shout out to Kieran, kiss my privilege. Kieran, Kamal, thank you for being here tonight. Also Lisa, Mary Polly, shout out, organizer of the International Social Prescribing Conference. Any question before we move on to the next presenter? So I've got a question for Michael, that might be an interesting one. So when the concept of HLP started off in Portsmouth in 2009, it nearly took, I would say, if I'm correct to say that, nearly 10 years for it to become mandatory for pharmacies to kind of include a HLP framework, as well as having a dedicated trained HLP champion. So in your opinion, based from the previous time frame required for HLP, how long do you predict that will take for social prescribing being fully integrated within the community pharmacy model, as well as, like you said, having a social champion, a social prescribing champion as mandatory for all UK pharmacies, in your opinion?
I think we can make it quicker, and it's partly for pharmacy to adopt it. That was partly the challenge, was the resistance within the profession and the sector itself, rather than commissioners. Now, we went through a process over 2 or 3 years of it being part of the quality payment scheme to bring it in. But before that, remember, we had something like 4,000 healthy living pharmacies before it was ever commissioned or mandatory, because people knew it was the right thing to do. And actually converting the people who want to do something is going to be far easier. And now we've got the platform of healthy living pharmacy in place, and some of the skills and the passions that go with that, the ethos that underpins it, then building social prescribing into that should not be such a challenge. So I would be very disappointed if we can't turn that around once we get through what we're suffering at the moment, which is holding a lot of change back, but is also driving change. And driving integration, then I would hope that we should, if a few of us got behind it, that 3 years would be a possibility.
3 years. Thank you so much, Michael, for such an inspiring presentation.
Don't hold me to that.
No, it's okay. Actually, now we got a nice segue for our next presenter, being Jennifer Neff from Elemental Software. So one of the key issues that might be for many pharmacists is time it takes to do referral or any existing platform to actually kind of have a platform being as a referral agent to a link worker. And Jennifer is a co-founder of Elemental Software, which is basically a social prescribing software, social prescribing tech. And for me, she's one of my heroes because she was one of the first person to believe in my vision and actually agreed to do an interview for my book. And she's been supportive ever since 4 years back. So thank you so much, Jennifer. Without further ado, let's welcome you to do your presentation, Jennifer.
Thank you so much. And hello, everybody. And yes, I will never forget the first time when we spoke. I was living in Dubai at the time, and Aaron interviewed me for his book. And I remember where I was and everything. So it's great to see. And you really are such a great champion for social prescribing. And congratulations bringing everyone together today.
Yeah.
So let me check the time here so I don't go on. I have a couple of slides here to show you and tell you a little bit about our own kind of journey through social prescribing, because everyone kind of remembers as well where they were when they heard about social prescribing. So our journey, we started about 8 years ago, and there's myself and Leanne Monk, and we were community development workers working in some of the most socially disadvantaged communities in Northern Ireland. And it was just really, really difficult. There was, you had referrals coming in all directions. You were designing your programs, then you had to promote your program. And, you didn't get a marketing budget for this type of thing. So you'd be putting up little posters in the corner shop or in the parish bulletin. You might put a little thing in saying, learn how to use Skype and, come to this community centre at 7 o'clock on Monday night. And it was really, really tricky because you were still having to source funding for your projects and your programs, and then you had to do all the reports and all the evaluations. And it often felt at times where you were powerless, and you knew how much of a role you were playing because you really were at the cutting edge and the front line for so many people's lives. And because people have such complex lives and so many issues going on that handing someone a leaflet or directing them towards a council website and saying you'll find everything you need on there doesn't really do it for a lot of people, unfortunately, because there's so many things going on in their life. So Leanne and I kind of thought, right, let's try and do this and connect people so that you've all these things that people can engage in, and then you've got lots of people with health and well-being risks. Let's see if we connect the two together. So at the same time, Sir Ken Robinson came to the city of Derry, where we're from, and he told us, when you find your passion, anything is possible. You're in your element. So we said, yeah, that's what we want to do. We want to make it easier for people to find their passions. Obviously, there was all the stuff happening in the Marmot report. We understood the health inequalities that were happening because we were working in the community. So we knew that just depending on where a person lived, the life expectancy could change by up to 15 years. But at the same time, it was the first ever UK city of culture, and Derry, there were so many things going on. So we said, let's see if we can do something. And I think, when I look at all the different kind of descriptions and definitions of social prescribing, I think this really, really puts it well. And I just stumbled across this the night before last, and it's Sinead Murphy. And she said that there's so much kindness and compassion and good nature in communities, and it's there for everyone. We just need to give people different ways to engage in it. And I think that really, really sums it up in such a lovely way. And I think that even looking at the whole community pharmacy side of things, so many people will go to their community pharmacy, but they might not go to their GP. So I think it's just really topical, and it's really good timing for this conversation this evening. So social prescribing for us, it's more than just signposting or health coaching or a directory of services, because it really is centered around that social prescribing link worker, that well-being officer, that community navigator, whatever the name or terminology you want to use. They are the most important people in the whole process. They are the people who are really working in some severe issues for people. Today, there's so many examples in Social Prescribing Day and stories about people who there was a story this morning with all the Merton guys in Southwest London, and they talked about this man who things had gone so wrong for him that he lost access to his children and things were really in a bad place. But his local social prescriber was able to help him kind of rebuild his life again. And he was able to get to see his kids again. He was able to get back on top of his financial issues. His housing issues were sorted as well. And you even hear stories in Salford There's a girl called Debs, and she was the social prescribing link worker of the year, just awarded last week. And she was actually working with Iranian guys, and she helped them even to source a bicycle so that they could go and they could volunteer and they could get the support that they needed. So it's much more than, you know, just being prescribed to go to the opera. That's great too, but for many people it is a lifeline. So the challenge is that when we first set out that we listened to, and we spent a long time listening to the point that people said, would you ever get on with what you were doing? But it's really, really important for us to listen. So people, we listened to health and housing and social care professionals, and they said, yeah, we want to make safe and secure referrals to the community and voluntary sector. However, we don't know everything that's available. We wonder, are our patients going to be looked after properly? And then we never hear back. You know, when we make a referral, we never hear back. And then we spoke to the social prescribing link workers in the community, and they were saying, look, we're carrying around paper and folders and spreadsheets, and we want to be able to work remotely, track and measure all the difference of the work that we're doing, how much time we're spending with people, why they were referred, the type of support they were getting, and the difference it's made as a result. They needed to report as well, because there's so many different funders in social prescribing that, you know, you have to report on quite a high level on a lot of different things. So they were struggling with that, and they wanted to reach more people. That's what their jobs are all about. It's all about supporting and empowering people. They don't want to be stuck behind a computer or stuck with writing out loads of reports and things. And they just needed an access to something alive and interactive, updated directory of services, because we know a lot of websites can go out of date really easily. And then we spoke to the patients, the residents and the citizens, and they said, you know, we've heard about this thing, social prescribing. How can we access this? We don't want to always be relying on medication. We want to know more about what's happening in our local community. We want to know about things that are free, and we want to be able to get support to engage in a lot of things, because people say, oh, I would have gone to that free swimming on a Friday morning if I'd have known about that. But other people said, well, I would never have gone. I don't have the confidence, and I might need someone to go with me. And then finally, the commissioners. The commissioners needed to know about the analytics. They wanted to be able to say, right, the difference that their investment is making in community health and well-being. And without that, it's very difficult to prove the effectiveness of things. So Leanne and I said, right, let's see if we can give the power back into the hands of the community so that they can receive referrals from lots of different sources. So they're not having to sit with telephone referrals and email referrals. Let's give them some kind of platform that can standardize the process of referrals so that they can report easily. It helps them increase the awareness of the services they offer. They can reach more people. They have the data then at their fingertips to be able to prove this is the difference, the service that we're making. And all in all, strengthening the relationship with different partners and different organizations and agencies, and reducing the time that they're spending on administration. So Leanne and I, we don't have a techie background at all. Remember, we're still community development workers with a big vision and tons of determination and passion and grit. And we said, let's build a platform that's going to help support and empower people and help reduce the workload of the link workers and standardize things and help to report on everything. So we set out and we started off with we didn't win, someone else won a pot of money, and he said that our idea was better than his. So he gave us the £500 from a little pitch competition that we did one night. And we managed to build a little prototype and we tested it out. And then we took it to NHS Expo in 2016 and we did 80 demos in 2 days. And we said, look, do you like this? If you had access to this, would you pay for this? And would this help you? And people says, that would be great. Actually, we'd love that. So we secured 4 customers within the first 4 or 5 months, and we were off then, and it was great. And all in all, we've been developing this platform over time. We now integrate with the GP systems, and we're about to announce integration with some social care and mental health systems as well. And we would love, obviously, to find out about the systems that are used in community pharmacies and how we can integrate with that. We actually push the SNOMED codes for social prescribing. There's little codes and they can be pushed back into the clinical systems. We developed a thing called elemental self-refer because we believe that you shouldn't have to go to your GP to get a social prescription. Yes, you can be introduced to it, but it doesn't make sense to think of people phoning up for a GP appointment to get access to social prescribing. So we developed a little elemental self-refer. This was just as COVID was starting. And this enables people to refer themselves, and carers can refer people directly into the social prescribing programs and the link workers. And then there's lots of elemental reports as well. So for us, it was all about the NHS Common Outcomes framework, because we always look in terms of nationally and policy. We're very much driven by what's happening on the ground. So it's like a kind of bottom-up approach, but we also like to look at where things are coming from the top down. And we looked at the impact on the patient. We wanted to help improve the impact on the community, and we wanted to help prove the impact on the health and social care system. So in terms of the impact on the patient, there's lots of different measurement tools in there in Elemental. Some of the stuff that we're loving at the moment is the MyCaw measurement tool. It helps to focus on someone's concern and how concerned they are about that thing. So Marie Coley's been working with meaningful measures, and that's a fantastic tool, and we're starting to see more people using that. There's SwenWebs, and then you've got like the ONS4 tools, lots of different tools that are being used. In terms of the impact on the community, we wanted to be able to show here's the number of referrals, here's the reasons for referrals. We wanted social prescribing program providers to be able to say, look, we have not got the capacity. Look at the amount of referrals are coming in. We need more link workers, or we need more services like the men's shed, or this particular gardening is really making a difference, or this food bank needs more support as well. So we want to be able to really show the difference it was making and the type of engagement. And then ultimately, everyone always talks about what's the difference in GP appointment and A&E admissions and reduced waiting times and things like that as well. So our footprint has grown. Yes, we're based in Derry, a fantastic place called Derry. I recommend everyone should come and visit Derry at some stage in their lives. But we have grown for much further and wider than Derry, and we're used all over. So in Scotland, we're used a lot of community and voluntary sector organisations. One of the biggest social prescribing programmes is the Spring programme, and they would use Elemental, and they would be providing support to tackle loneliness and isolation. There's also an organisation called the Scran Academy, and during COVID, they were actually delivering meals to people. But while they were delivering meals, they were obviously able to help with some more social support as well. And then when you move down, we're in Sunderland, northwest of England. Greater Manchester Health and Social Care Partnership commissioned us last year, the largest contract that we'd ever received. 400 GPs making referrals to 100 link workers, some based in primary care networks, some based in the community and voluntary sector organisations, some even based in mental health trusts as well. And then there's thousands and thousands of community sector activities and programmes that are being referred to. Merseycare NHS Foundation Trust has a great example, secondary care provider of mental health, but they also provide community-based life rooms. And these life rooms are like old libraries that have been converted into beautiful buildings where you walk in and people are just sitting playing cards and chatting, and they're able to talk about their mental health. So there's 3 of those in the Liverpool region. We're all over Wales as well. A lot of the commissioners in Wales are delighted with the funding the data that's coming from Elemental. One of the commissioners said, I spend £500,000 on social prescribing, and the data that's been collected from the projects that use Elemental is helping me to realise that that's money well spent. And he's now looking at recommissioning for the next couple of years. We're also in Bristol and Somerset and down in Cornwall as well. And we're in 50% of the London boroughs use Elemental. So very different in every place. We've just signed up a project there, and it's around wounds treatment. So the team that go out to help people with their wounds, be it diabetes related or other long-term conditions related, they're actually providing more than just the wound support. They're able to support them in terms of social prescribing as well, and connecting them in around debt advice and social welfare legal advice. So that's just some of the projects. Lots and lots of like you'll see from today, this is the 3rd year of Social Prescribing Day, and wow, it has just really taken off even more than I could ever imagine. There's so many people thankfully engaging in social prescribing. We have over 81,000 people benefiting, patients or people or residents benefiting from social prescribing. There's nearly 10,000 GPs, nurses, OTs, practice managers, local government staff, social workers using Elemental to make referrals. And there's over 1,700 social prescribing link workers using Elemental as well. And that means that they can connect people into all these different sessions and activities and track all these visits and all the difference that it's making. Lots of different people use Elemental. It really depends on a project and what the inclusion criteria is, or what they're set up to do. So if it is something around social isolation and loneliness, or if it is around dementia, or if it's children and young people social prescribing, they'll look at who can refer into our project. And the process is really inclusive and it's really enjoyable, but it's all stakeholders around the table. and they're talking about the referral pathway, and they're talking about what the data is that they want to share with each other. They talk about what does success look like, what's the vision for this project. So it's great when you're part of something like that, and we've been a part of so many discussions now. It's been fantastic. So what a project normally does is they determine who their referral agents are. Then they look at their referral handlers. There might be 10 social prescribers, there might be 6 within the community and voluntary sector, and then there's 4 within the primary care networks, could be a combination. Then people look at the providers. So they say, some people actually put it out there and say, we're doing this. Does anyone provide creative writing classes, or is anyone doing any art classes? And lots of different providers can join and be part of it. And then there's a view as well for the patient, tenant, or the citizen. They can see what their social prescriptions are, and they can track their kind of journeys as well. And then finally, there's that commissioner dashboard overview as well, which is great. This is just one little example. I always talk about this. People probably think, here she goes again, but I just love this because they just really, they just love the kind of digital side of things, but it doesn't get in the way. It's still a face-to-face service. Digital's in the background. They can receive referrals in from GPs, other third sector organizations, self-referrals, and crisis support. And I think this particular project is working with maybe 15 different GP practices and primary care networks. They would do their assessment. They go through find out what the person needs and what matters to the person and what the person enjoys. And then they would connect them up with all the different types of support. So at the moment, you'll not be surprised, there's lots of food bank support, but they're destigmatizing that. And they have like food clubs and things, creative writing classes. There's all kinds of guitar classes online. They even prescribe apps as well for people, which is amazing, and loads of volunteering and employability. And they've been able, their commissioner is delighted because their reports go back to the Knowsley CCG. They're able to say, yeah, brilliant, let's keep funding this. Let's keep funding the digital aspect of as well. They've just recommissioned Elemental now for another 3 years. I don't know how much time have I got here. I don't know if I've got maybe much to go into this, but this is a kind of just a typical example of someone. So this is actually a real example of Alan, presented a GP practice with post-traumatic stress disorder. Doesn't have many social connections, served in the Gulf and in Northern Ireland. Anger issues led to divorce and recent trouble with the police. Self-medicating, socially isolated because he doesn't fully trust civilians. And as a result, mild depression and anxiety. He's in debt and he's facing eviction. Now, this is the harsh reality for a lot of people. And this is the harsher reality for a lot of social prescribing link workers. So you can imagine dealing with the types of issues that people are living with. It's really, really challenging. So one of the things we keep advocating for is training and support for social prescribers, and really to give them the respect that they need and the escalation pathways. If sometimes social prescribing can be a bit of a dumping ground and people think, oh yeah, just, make a referral over to the social prescribing link worker. So there is a lot of kind of thought, and there's a lot of great work, and Dan Hopewell will talk about this as well, the great work that they're doing to build up the capacity and the support networks around social prescribing. So Alan then would have been referred by the GP to the social prescribing link worker. They were able to make contact with his housing association to discuss a payment plan. As a result then, he was able to join a defence garden scheme for 12 weeks. So these are popping up now. You'll see them in lots of different parts of the country. And he was able to deal with his anger management issues. He met similar men from similar situations and formed relationships. His improvement in well-being has improved, his reduction in anxiety. He's less concerned with the things that were concerning him at the start. He's joined a walking club and a men's shed, very busy, and he's able to meet with the social prescribing link worker a total of 7 times. Now, in an ideal world, less GP visits and less any attendances, but what the digital side of this has been able to do is to show you, because that's a great story there about Alan, but people drop out at different points within the social prescribing journey. They might get the referral and never meet up with a link worker. They might meet with a link worker once and then not have the confidence to go back. So what the digital does, it is able to keep an eye on the person and see how they're navigating through the services. I want to show you 2 last things, and then there's an online demo, an open demo next week if you want to join and see. This is the self-refer. So very simple. A carer or someone could go onto a community organization website and fill out a little form. This example was someone filled out a form for a fridge for his medication, and because he had cancer. And the social prescribing link workers were able to approach the local Chamber of Commerce. They got connected in with a provider of white goods and a brand new fridge was able to be delivered to this man's house. So it doesn't get more personalized than that. This is the last thing I want to show, and it's the integration between us and the EMIS system, because I want to show how easy that is. So you imagine a patient comes in, GP thinks, right, this person would actually really benefit from social prescribing. They don't even have to leave their clinical system. They just click on the social prescription button, pulls up an express referral, click on the express referral. It pulls across demographic data, no clinical data. It asks them to do two things. It asks them to do the reason for referral, and it asks them for the patient consent. So here there's a drop down. This all goes into reports, so you can report by this, but you can put in as much information here for the social prescribing link worker. You can even safeguard that social prescribing link worker to let them know that this person might not be suitable to see alone. You can put in access needs in terms of interpreter or learning disability, something that is able to flag that up. And then you get the permission then from the person to be able to send the referral across. Now, the new thing that's happening is around these SNOMED codes. It automatically generates a SNOMED code now that sits within the patient's record. So that will say social prescription offered. Whenever the patient then is in contact with the social prescribing link worker, if the person declines, it'll push a SNOMED code back in and it'll say social prescription declined. It'll give a bit of information around that. It'll just say who the social prescribing link worker was and where the center was. If the person accepts, it also pushes a SNOMED code back in to say that it was where the referral was made to, and also who the social prescription or who the social prescribing link worker was. So the next phase of this is we're trying to push some unstructured text back in the form of a little bit of a narrative so that can go back in. So it's making a massive difference for people on the ground, because it can be quite administrative, as you can see. So yeah, join us next week. We are doing a demo. It's been a long day. And we're doing an open demo on Wednesday, the 24th, between 12 and 1. So just book in. All the details are on the website. We're also doing a webinar to show the integration between the two systems. We also integrate Revision and System 1 as well. So I'll be able to share this. Maybe Aaron can share this afterwards. Finally, what's next for social prescribing? We're going to see more and more children and young people social prescribing. Money's come out there for green social prescribing, so lots and lots of projects are starting to tap into that. Social prescribing for pre and post dementia diagnosis. I've been involved in so many recent conversations around that. Big thing will always be the core funding for social prescribing, and it's because it's really, really important, because without that, there's going to be no link workers, there's going to be no community and voluntary sector organisation, there's going to be nothing to refer to. Increase in the number of social prescribing link workers, we're starting to see more and more of that. More training and support, as I mentioned earlier, and as always, more evidence being gathered on the uptake and the impact, and being able to understand that data and really analyse it and see the difference that's coming about as a result. So Sinead, as they would say in Ireland, thank you very much everybody for listening, and I'll take any questions, or I'll wait till later if you want.
Well, thank you so much, Jennifer. I mean, like, every panelist here today got so much content to talk for 2-3 hours if needed, and there is so much content. And I didn't have to stop you halfway through because you're in your flow state, and you were delivering a lot of content. And for pharmacists in the audience, basically, I already spoke to MS with a gentleman called Chanel, who was a clinical pharmacist at MS company, and then also spoke to Kevin from PharmAdcom. So for people that are using Prescribe, that is a EMIS software, so potentially is like enough interest, you can get Prescribe to involve Elementor's platform at community pharmacy referral. And probably question be kept later on, but honestly, thank you so much, Jennifer, for your powerful energy. So without any further ado, let me present Dr. Bogdan Chivagoiaca. He is the reason behind this conference today, because he is the founder of Social Prescribing Day. He inspired me at his very first presentation 3 years back when he said, okay, I'm a medical student. I managed to get every medical society in UK involved in the social prescribing scheme. And he inspired me. I'm like, wow, it's not just a titan industry, it's also next future generation. And his work leads phenomenal work around the globe. He's part of NAS. He's led the foundation for the Champion Scheme. He's part of the Global Social Prescribing Alliance, which we have Gary talking later on. So I let the man himself talk. So thank you, Bogdan. Thank you, Jennifer.
Thank you so much, Aaron. What a fantastic introduction, but not well deserved, I'd say. I think the reason why we're here today is you're all the reason why we're here today for this conference. I think what a great panel, and Jennifer, amazing talk as usual. And Aaron, I can promise Jennifer goes in that flow state all the time when she speaks. It's a normal state, and it's great. And she's been an enthusiastic champion for social prescribing. Great to see such embedding of social prescribing in digital platforms, and Jennifer has been there from the beginning of the movement. Great to see Dan, great to see people I've seen in the past, and we haven't managed to catch up in a while, so such a great pleasure to be here with you today. So today I'm wearing my National Academy of Social Prescribing hat. And I want to speak to you about a few different areas of work. I'm aware that Gareth, who is also an amazing mentor, but also pioneer of the subject, will be following after to speak a bit more on the Global Alliance of Social Prescribing and talk about integration of sustainable developmental goals. So I won't cover too much of that aspect, but I will cover a few things more on the championing of social prescribing and why we need that, especially with the Social Prescribing Pharmacy Association and with multidisciplinary teams that need to come together. So first and foremost, I think whenever somebody mentions social prescribing, it's got so many different connotations nowadays that it's hard to keep up. And I think that's one of the maybe things to blame social prescribing for, or I'm not sure if it's a strength or a weakness really in that sense. But I always think of it as a model and a concept. So if you think about social prescribing as a model, it is without saying that without the link workers and without the community connection and without the person facilitating that connection, social prescribing would not exist, and social prescribing would just be mere signposting. So I think that's one of the most important things that I always keep in mind. I always chat to students about, and I always make sure that all of our champions reflect in that sense too. However, when we look at the concept of social prescribing, which is something that is emerging more and more and more, and it just hits home for so many across the world, I guess, and even internationally, this has so many connotations. And I've spoken to students in Boston, spoken to students in Japan, spoken to students all across the world, and all of them talk about this culture change and this shift in values and beliefs that they name as social prescribing. Well, they kind of zoom a bit out and they go a bit one step back, and I think they talk more about personalized care, shared decision-making, biopsychosocial model, co-creation, co-design. So all those values that we hold dearly and that social prescribing first fosters in that sense. So in a way, for me at the moment, I think social prescribing as a concept, so yes, it's formidable to see the model of social prescribing in action with the link work, and we should build upon that. And today's Social Prescribing Day is a day to say thank you to the link workers. But as a concept as well, it's very interesting to see how it's bringing multidisciplinary teams together. It's stopping that divide, the us versus them. So I would often be in the hospital and I'll get an occupational therapist saying that the patient's under you, not us. And I'm thinking, no, it's under us, because we should work as a team in that sense. So for that reason, I think social prescribing as a concept has the potential to hit home with many people from abroad, especially with those students in medical schools across the world, and not just medical students, but pharmacy students, nursing students, occupational therapy students, who are still being taught in a model whereby they're being taught to tell patients what to do and exactly what to do, when to do. And I was talking to Gareth the other day about this, and we were saying as well that this will become impossible given the population needs soon. You won't be able to do this because you have an ever-growing, ever-increasing population that's going to double by 2050. You will have a workforce gap and a shortage in workforce, and you really have to start thinking about ways of meeting patients halfway and doing things together with them and getting them to share that responsibility, if able to, of course, and to get more involved in their health and to use digital solutions like Jennifer was advocating for earlier as well. So what are we doing? Well, I guess the main mission of NASP, of the National Academy of Social Prescribing, is to simply help people live the best life they can live on a daily basis. And I know that sounds very ambitious, but that's certainly what we wish for all of you and for all of us to do. And we have different initiatives that help us do that. One of which is a clinical champions program that we're hoping to launch next year. And this is perhaps one of the ones to watch out for, multidisciplinary teams across not only the UK, but across the world. We'd love to have clinical leaders in various areas representing different disciplines coming together to advocate for social prescribing, to understand more of the model itself, but also the concept itself, and to help us build a bit of a narrative in shaping social prescribing further as well. And I guess that leads a bit more into the global work that Gareth will be talking about, and the Global Alliance as well. What I also wanted to mention is this idea of workforce and how we can use these concepts of personalized care and the concept of social prescribing to prevent burnout in the future generation, and to help the future generation of students to get some hope from this concept. And whenever we speak to students about this, and I started this, when I started this I was a student at the time, and I remember thinking we are not doing enough for our patients. And I remember seeing this paper, and I keep going back to it. It was in a famous, I think it was either The Lancet or another famous journal, but they were saying that the biggest barrier to personalized care, to doing these conversations in the hospital and co-creation and co-design is time. And I kept looking at that, and I just disagreed with it. And I was thinking, yes, it's half true in a way, because we don't have time. We have 10 minutes with every single patient, you know, in a consultation perhaps, and we struggle to find the time. However, we know research has shown that those who are educated with the principles of personalized care, co-creation, co-design, and know what social prescribing is, there's papers that show that they perceive the work that they do as less strenuous and less stressful in that sense. And yes, it's going to take me a while to get a patient going using those principles, and I might invest 10 extra minutes a day, but that's going to save me so many extra minutes in the future if I prevent disease in the first place, and if I co-create and co-design a program with the patient in that direction too. And so when I keep looking back at that paper with the biggest barrier is time, I agree, but at the same time, I'm thinking that time is always relative and is what you make with time in that sense. And so I think what I also wanted to say is that what makes this movement big is that its power is in its people. And I think you'll see this with the panelists today, but with all of you in the audience as well, and the noise that is out there and on Twitter and social media. Everybody is just simply joining with no agenda other than joining forces to make sure we live better, we age better, we support the younger ones to live better into the older years in that sense as well. And that's very emotional to see, certainly on a day like this. And I would say we need to build upon that movement further, and we need to continue working together, and we need to expand the purpose of this movement outside of the UK to share learning. I think that's one of the most important things, is that we're saying we don't want to go abroad and teach others. We want to go abroad and share learning with them and promote what's been happening within the local communities. We know evolutionarily, we've all worked in tribes. We've all had our own communities across the world. And here's the time to harness those communities and to share what we've learned and promote what they have learned as well. So I'm going to end there. I didn't want to bore you. It's been a long day for me, certainly as well. My fingers hurt from the amount of tweets that I've been writing, and I feel like I still haven't covered saying thank you to everyone enough. Already, but I want you all to stay involved in the movement. I want you all to contribute to any documents that will be coming from this. There's a long conversation around the medical school curriculum and the other healthcare student curriculum developments that we all need to get around to chatting about. We led a bit of a project for the past 3 years, which we're just concluding results from, and we're hoping to get together for one final stakeholder meeting to finalize a bit of a framework on how to teach social prescribing across the UK. And I know that's of interest to many. So if you'd like to hear more of that, do stay in touch. Get in touch with our students. There's going to be loads of regional champions across the UK. If you have an idea for an event, get in touch with them. If you have an international idea for an event, get in touch with the students as well. And they'll be there and they'll be happy to support you as well. And they would love to learn from you all. So once again, Aaron, congratulations for this fabulous event. Thank you for having me. I look forward to listening to Gareth as well. I know he's going to be touching a lot more on the Global Alliance picture as well. And pleasure to see everyone in the audience and in the panel as well. Thank you.
Thank you so much. I mean, Bogdan, like you got such a powerful voice that get people around you. I mean, you've been in this field for so many years and you must bring about a global movement around you. So hats off to you. And definitely people watching this conference tonight, do get in touch with him. Such an inspiring person. He is very open to ideas. He will listen to you, give you ideas if you're starting from scratch, like he did for me. So definitely get in touch with him, look at his work, and without any further ado, let me present Gareth Pretch. It's been such a long time. I mean, all I can say, thank you so much for doing an interview with me for my book again and being here again tonight for the conference for pharmacy. So Gareth has done so much work. He's the founder of the World Health Innovation Summit, and then so many other things. So I just leave the man to present himself, such a titan. So thank you, Bogdan. Thank you, Gareth, to introduce yourself.
Thanks, everyone. It's a pleasure to join everyone here this evening. Grateful for this opportunity to speak to everyone today. And I think we've had a fantastic day with the Social Prescribing Day. Congratulations, Bogdan, big success. And here in Matt Hancock pledged his support towards the Global Social Prescribing Alliance today as well, pushing the UK at the forefront of our alliance's work, shall we say, with World Health Organization, with the United Nations Global Sustainable Index Institution, with the World Health Innovation Summit, and of course, National Academy of Social Prescribing. That, of course, will extend into NHS and other partners around the world. So let me just start by, I'll just share my screen and just give you a bit of an insight into exactly what we do. In terms of the World Health Innovation Summit, a little bit of background about myself, who I am, what I do. I have 20 years experience. I was a former chief officer at the National Haemophilia Council in Ireland. So hence my accent. Jennifer will certainly know I'm from Dublin, which is the south of Ireland. And so I originally am from Dublin. I have two young girls. I moved to the UK about 6-7 years ago. Joined the NHS actually, and set up the World Health Innovation Summit as a platform to support the health service. As Bogdan mentioned, the reasons why, shall I say, why are we doing what we're doing, and why are we seeing this huge transformational change? Just to state a couple of things. Firstly, I am the CEO of the World Health Innovation Summit. I'm the expert lead on Sustainable Development Goal 3 for the UNGSII Foundation. You may be saying, what is the UNGSII Foundation? Well, it is the foundation that was set up by the United Nations Director General Michael Muller, Kofi Annan previously, to implement the 17 Sustainable Development Goals around the world in 25 cities and 5 Indigenous communities as a front-runner program. And that's led by Roland Schatz, who was the former advisor to Michael Muller and the UN Director General. I'm also a member of Pope Francis's COVID-19 Vatican Commission, which I was appointed in March last year to look at the future. And in terms of context from the healthcare perspective, the Vatican and the Christian Church are about 26% of the health economy in the world. So they are a significant player in terms of global health. And I'm also the founder of the Global Social Prescribing Alliance. And we'll go into more detail around how we can leverage this support. Firstly, as Bogdan mentioned, and I thought I would show this presentation because it's very relevant to today in terms of One Health and in terms of the pandemic. In 2019, I made a presentation at the One Health European Conference in Bucharest, and I discussed the issues and the problems and the challenges that we would potentially face from a pandemic, not a coronavirus pandemic, but from a pandemic, because we had expected this to happen for many years. If you look at Event 201, for example, we've been kind of, shall we say, anticipating this for many years. But as Bogdan mentioned, staff-wise, by 2030, we'll be 18 million short worldwide. That's a huge problem. You know, at the moment, I think there's about 100,000 vacancies in the NHS. Global health spend is accelerating. Wellness spend is accelerating. It's a $12 trillion market space. The global population will jump from 7.6 billion up to nearly 10 billion by 2050. The number of people over the age of 60 will reach over 2 billion very shortly. The world is totally ill-equipped for this at the moment, and we see this as a result of the pandemic. Our health systems, our health and social care systems, while many of the systems within the European region would be considered advanced, you can see that we still have major problems. So the opportunity exists in this, shall we say, the process of disease, looking at well-being and the factors of well-being. That's really what social prescribing is about. Moving from this pathogenic approach, which is what we currently do, which is the treatment of disease, into the process of disease, and just looking at the support, shall we say, the factors of good health and well-being. And this green area here is where the growth will be. This is where the opportunity is. And I'll explain how we create the value, how we move from a system that is absorbing, can we say, costs and funding to a system that releases value creation. And that's really what social prescribing does. I was listening to Jennifer earlier around Alan, the example from Alan. And that's a good case study actually to show how much money can be generated and actually financial return can be generated through social prescribing. And I'll go into more detail in that as we go on. The WIS is a platform for global opportunity in terms of an access to a market space of $12 trillion. We are an entry point into any health economy in the world. And that gives us an enormous opportunity to leverage that to create a sustainable platform for good health and well-being. That's very much what we're driving towards. And this is the kind of model around which we prototyped in the UK, which is around supporting children initially, you know, WIS kids around their health and well-being, WIS at work, stress management in the workplace, WIS seniors, which is falls prevention, quality of life, loneliness, but also wisdom and knowledge sharing. And then green, which looks at energy, waste, and water. If you don't have health or water, you've just got no health and well-being. And so this is the sort of area that we're focusing on. This is what has been adopted by the UNGSII Foundation to support their programs. We will be initiating this in, for example, Kinshasa, Sikkim, various different jurisdictions around the world. We've just had, I will be presenting this work, chairing the G20 in Berlin in May, where we will meet global leaders to discuss how we implement and support a recovery from COVID-19. What does it look like? Everyone kind of says, what is it? And we have programs that we had in schools, unfortunately, not running at the moment. We have some kicking off in Switzerland. And we intend to bring each one of these programs to those cities, which the 25+5 are also supporting UN Habitat. The value proposition, and in terms of how does it work from a monetary perspective. So I just want to give you the example there. That's WIS Nottingham, where we held an event where we had 5,000 people come to the local city centre. And you'll see that is an activity there where you're supporting health and well-being. But think of that and look at that picture as your GP practice at scale. And really what you're able to do then is reach mass numbers of people to improve their health and well-being, at the same time to create economic value and job creation within that local economy. And you can do that in any city around the world. The pound invested 36 back, that then gives you an economic value or an opportunity cost in terms of job creation, is substantial, because you have a $12 trillion market space. That's how you generate these future jobs. And that's how you create your new economic model. And then you can recycle that cash flow within the local communities and continue to grow. Because the whole idea is we're a social enterprise, profits after costs go back into local community. So you're reinvesting that cash flow back into local communities. And this really is kind of to give you an economic understanding of how financial markets work. And this is really important to understand. For example, through COVID-19, we've had 400 million job losses, but at the same time, the top 30 companies in the world have generated over 100 billion pounds in profit. And what is the percentage of that profit going back into local communities? Well, it's less than 0.5%. So the future companies and the future enterprises that we support as a community should be those that give back, and that's based on the Sustainable Development Goals. And so what we're doing is working with the investors around the world and those who want to invest in sustainable products and services. We have proven that if you invest in platforms and companies that do good, you get good back. And that means it's extremely economically viable to do that. I'll talk a little bit more as I go on. In terms of the SDGs and the opportunity, in terms of infrastructure and where we go, 70% of urban infrastructure doesn't even exist, at this particular, by 2050. So there's a huge opportunity in terms of infrastructure. But from the health perspective, as I mentioned, the growth area, if you look at the link workers in the UK, for example, that is going to go from 1,700 up to 26,000 in the next couple of years. So that's a huge opportunity to grow, employment. And the SDGs gives us a blueprint. It gives us a way forward, and it's also recognized by almost every single nation in the world. Working with the foundation of it, the opportunity to work with the European Commission, the first Vice President of the European Committee of Regions, Marco Marcola, there presented our work at the European Union, spoken at the World Economic Forum, at the Davos Lab, at the SDG Lab. I fortunately as well have had the opportunity to meet with Pope Francis to support the Corona perspective. We are working with the International Parliament, IPU, UN Habitat, UN Academic, which represents 1,300 academic institutions around the world, African Union. So we really have a great opportunity here through the Global Social Prescribing Alliance as well, to bring these examples of best practice from the UK, from all over the world, and then ensure that that best practice and knowledge is shared so that we can ensure people improve their health and well-being. We have published books in this area, Intellectual Capital in the Digital Age, and we are seen as a sustainable platform for the future. So the beauty about the methodology, it's all open source. It can be replicated around the world. The idea is to develop this in jurisdictions. We're talking to Australia, we're talking to Canada, Singapore, but also our partners through the 150 cities that we're engaged in with UN Habitat, for example. And we are receiving projects on a daily basis from Kinshasa, for example. We got some of the projects last week. These are developing new hospitals, new infrastructure around the world, supporting them in the future. How do they not make the mistakes that we've made in the past? And how do the investments flow into new and meaningful jobs while improving people's health and well-being? This is the SDG One-Stop Solution platform that we're working with the BMJ and Dr. Angela Merkel's government, Gunther Noki's office, the BMJ and GIZ in Germany, and we will be developing this across Africa. First site is in Kinshasa, where we will identify projects for the local community, and we will match make them with investment through our partners, and then just make sure that the investment flows into the right area. Some of the stuff we're engaged in, Concert for Humanity, SDG Orchestra, these are other examples that are very much related to social prescribing. And then this is our SCR 500, which is around leveraging that investment that I mentioned. We are able to map out what companies are spending their money on, and then ultimately leverage that towards a fund, which we have ourselves, which a cumulative return is over 50%, which is highly desirable for pension funds, for example. And then we're able to invest into projects. And that's how this whole mechanism works. Next steps for us with the Global Social Prescribing Alliance, which we launched a couple of weeks ago with Hancock, James and others. Bogdan has been a big support with the students. We're very much looking forward to making it a program and a flat pack that we could then export worldwide. And then myself and James will speak at the Global Solutions, as I mentioned, at the G20 in May, and just put this on the table as a solution for the G20 to invest in for the future and to build back stronger from COVID-19. This final slide for me is really just to say thank you. The SDGs give us a roadmap to build back stronger. We can embrace the change. We can look to collaboration. We can see the collaboration across the board, new ways of working, being open, transparent, working with trust, working with integrity, Look at leadership. It's very much about supporting those who put their head above the parapet now, the ones who are delivering on change, taking those actions, that we stand beside them and help them along the journey. People like Bogdan, people like Jennifer, people like Aaron. It's very important that we all stand together and we move this along the line, because it's very clear here, if we don't make these changes soon, we are in big trouble in terms of climate situation and other, so let's anticipate the future. Let's not wait for these things to happen before we react. Let's start anticipating what's going to come, which we know what's going to come. We have great data. It tells us what's coming. So let's start putting these projects in place. And so that's it from me. I'll take questions later on as well. And it's been a pleasure to join everyone. And I look forward to working with you all.
Thank you, Garrett, for such a powerful presentation once again. So for people watching this conference tonight, like we discussed about the micro, the intermediary and the macro level, and that's what Garrett was covering. And thank you for providing such powerful insight. For questions, let's keep it later on. We have a very tight schedule. So without further ado, we have Dr. Maria-Anne Sam, such a lovely person. I mean, I first approached her. I met her like 3 years back at the East Social Prescribing Conference. Very powerful personality. And when I messaged on Twitter, not expecting a response back, saying, I'm planning to do an online course. How do you feel about helping me do it? She said, yeah, sure, let's do it. When do we start? And that's how the online course came about, by her enthusiasm to support the people new in the scene is very supportive. Thank you, Dr. Maria and Sam. So without any delay, let's welcome you all.
Thank you. Lovely to be here this evening, and thank you for inviting me. And happy Social Prescribing Day, everybody. It's been a good day, and this is a lovely way to bring it to a full completion. And I'm delighted to have listened to that glorious global perspective. And from that world perspective, I want to just take you to the heart of the matter, because social prescribing is our opportunity to offer individuals who have lost hope, who've lost their way, who have got their lives all jumbled up and can't find their own way out, a purpose and a new beginning. And it is essential that we all come to appreciate that personalized aspect of health. Nobody's going to be interested in their medical aspects if they've got no motivation to get out of bed, if they're not meaningfully connected, if their housing isn't secure, their finances aren't secure, they're not growing and giving within their communities. And we've become very siloed in health and very siloed in society. And I think as we emerge from this pandemic, it's a real new opportunity to think what really matters to individuals and what really matters in the community. And social prescribing is the big catalyst to really bring us into a different kind of future and different kinds of communities. And as pharmacists, you are absolutely key in that community redevelopment. Sincerely, I'm just so thrilled to be able to have this forum to connect with you and to tell you what vital players you are in so many individuals' lives. And we will change communities and society and the world one person at a time. And you will help us one patient at a time, one family, one situation at a time, one connection with your link worker at a time, as you reach out your hand to offer that person the help that they need. You may well be the only person so far an individual feels they can trust, because sadly the system has let a lot of people down. A lot of people have fallen between resources that they didn't really quite qualify for, or they didn't turn up. It may be that you are the face You are the face that they just makes their day when they see you. You are the person that looks out for them if they haven't turned up for their medication on time. You're the person that's interested why. You're the person maybe that's interested in the carer who comes and collects big boxes of dressings. You're the person that reaches out and say, how is mum doing? And you will therefore find yourself in pole position sometimes to make that introduction with a social prescribing link worker, as somebody who can have that broader conversation and start unraveling the mess, start putting hope back in there, and start finding the solutions for that individual, for that carer, for that family. And as that multiplies up, you will see you're having an incredible impact, even above and beyond what you already do. And this is also a big win for you connecting with your local primary care networks, because the social prescribing link workers are embedded in those networks. As you reach into your primary care networks and offer relationship there, possibly even offering your consulting room as a potential premises for the conversation with the social prescribing link worker. Because if that's a place your patient feels safe, it's a good place to have a meaningful, life-changing, transformative conversation. As you reach into the primary care networks, your GP colleagues will increasingly see that you have even more to offer than they have enjoyed over the years. And of course, in the primary care networks, you have got pharmacists too. So actually looking in the broader round, because actually medicine's management and compliance and attitude to medicine sometimes actually masks much deeper psychosocial issues. I have to give a little shout out here to young Rav, who is on the call tonight, who is one of my very own practice clinical pharmacists. And even just this morning, we were having a conversation about a very complex family. And it's the pharmacists that are starting to actually give us as GPs a way in to a very tricky situation, which actually at the moment isn't even quite in a position to give to the social prescribing link worker. But blow me, my pharmacists look like they could be the very bridge into getting into this sticky situation, which has gone on for years and years, because it starts to give us levers for conversations which offer a different approach to well-being and progress. So, shout out to pharmacists. You guys are amazing. And there's a lot more you can do. And I look forward so much to working with you increasingly. You and us together, we will rebuild these communities. We will energize the local groups in the communities. My local pharmacist, he's forever sponsoring things that the local residents association do. He's the guy with the tea and the coffee for a clinical, for a community meeting. And things like that really make the difference. So I suppose I better shut up, because really I've only got 10 minutes because I hear Auntie Jennifer overran a bit, but there we go. It was Paddy's Day yesterday, so you're allowed. It's okay. And it's just lovely to be here, and I shall hang on around if there are any questions later. Thank you very much.
Thank you so much, Dr. Marianne. I really appreciate it. And what I love about you is just your enthusiasm. Like, it's so magnetic. You get people around you. From the very first meeting, was like, I didn't have a clear idea on how to get my concept of the online course into fruition. But he said, okay, so we can do this. That's a pillar of blah, 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 blah. I was like, I'm seeing something. And then thanks to you, after a few months down the line, because of the pandemic, we got the product. And thanks to your mentoring, there's over, I think from the latest statistic, 15 hours taught on online course with over 400 delegates from 64 countries. So hats off to you for supporting pharmacists around the globe. And so let's keep the question on the end, just to try to get everyone into timing, because I'm quite appreciative of people's schedule. And it's late in the evening as well, in the afternoon, evening. So let's welcome all Dan Hopwell from Bromley Bible Center. So what I love about Dan is that he opened my eyes when I went for Open Day at Bromley Bible Center 3 years back. I was like coming in. I just got an idea of combining dance and pharmacy, but it's only when I went to his Open Day at Bromley Bible Center, he explained about the top-down approach and bottom-up approach that was completely new term to me. And he also agreed to do an interview for my book. Thank you so much, Dan. And I leave the floor to you, Dan. There you go.
Thank you, Aaron. Thank you. And I'm going to attempt to do this terrifying thing of sharing some slides. So, okay, let's see if this works. Great. Except I think we may not be on the first slide. Right. Is that sharing?
Yeah, it is working. Yeah.
And great. Thank you. Right. Okay. Good. Some thoughts from Bromley by Bow about social prescribing, but I think a little bit wider than that as well. So that's the entrance to Bromley by Bow, to our health centre. And of course, it doesn't look like the entrance to any other health centre, I think you might imagine. And one of the things you will notice is that there's no blue and white NHS signage at Bromley by Bow, and that is completely deliberate. We, if you want to look it up on our website, there is a little paper called Stop Building Health Centres. We think that the concept of primary care health centres is really long past its sell-by date and probably quite unfit for purpose for the 21st century. And if we think about the modern pandemics, and of course we've been visited by many pandemics over the last 20 or 30 years, really. You know, we have a pandemic of loneliness. We have a pandemic of obesity. We have a pandemic of diabetes. None of these pandemics are really going to respond to a 10-minute consultation in a small consulting room. We know that. And so they continue. And I'm constantly reminded really of Einstein's law of insanity. You know, let's go on doing the same thing again and again, but expecting a different result. And so if we go on building health centers with small consulting rooms doing 10-minute consultations, we will go on failing to address the issues of our communities and the people that live within them. So we need to do something really quite radically different. And I'm going to tell you the story of a community that did something radically different about 35 years ago. So the photograph top right is of Bromley by Bow, a rubbishy 3-acre local authority park with, as you can see, having no care and attention to it at all. And the back of an East End church, and right in the sort of top right, with a funny arch glued to the back of the East End church, commonly known by local people as Dogshit Park, a park that people really spent very little time in. It was full of broken glass and dog poo and syringes. If we fast forward 35 years, you can see that same park today. It's 3 acres of beautiful parkland and food growing areas and a flower garden and a children's playground, used for umpteen activities, including big community fairs and so on, and a brand new health centre that we built as a community 22 years ago. So Bromley by Bow, an inspired and inspiring priest arrived there 35 years ago to encounter a tiny congregation of old folk and a semi-derelict church, and started to build a small community hub by what we would call today asset-based community development. Andrew Mawson, who's now in the House of Lords, called it loitering with intent. Walking the streets, getting to know people, getting to understand their passions and their interests, and inviting them with the blessing of the congregation into the church, which was really locked up every day except Sunday for a couple of hours, to come in and start to use these church buildings and build a small community hub. We also got to understand that the quality of primary care in our community was far from ideal. And about 25 years ago, we said we wanted to build a health centre. Well, lo and behold, our greatest opposition at that moment came from the National Health Service. The National Health Service had never heard of communities building their own health centres before. It was only really when Andrew persuaded Brian Mulwiney, the then Minister for Health, to come down and visit this small community hub that was kind of growing out of this derelict church, that Brian Mulwiney understood what we were trying to do and instructed the local health chiefs, who had spent several years trying not to talk to us, to allow us to build a health centre. And then the Bromley by Bow Centre, this small community charity, went off to the Norwich Union and borrowed £800,000 and built what we believe today is still the only health centre in Britain that was built by the patients and is rented back to the doctors. And at the same time, we persuaded the council to give us that scrappy local authority park on a 30-year lease. And we set about turning it into a beautiful facility and built the first healthy living centre in Britain. And we built it into and across the park. So we integrated the outside space and the inside space. Today, we have 4 GP practices and we support about 40,000 registered patients. And we see about 10,000 people a year in the community services that we provide. We have a team of about 80 staff providing non-clinical services alongside general practice. And social prescribing has sat at the heart of this model for 20 years. That's an aerial view of Bromley by Bow, and that kind of gives you an array of all of the services that we've brought together within one 3-acre park. We call it a campus. It doesn't have pharmacy within it, although we do have pharmacists within general practice, but I'm going to talk about the incorporation of pharmacy as well. As I say, social prescribing has sat at the heart of this model for the last 20 years since we opened the Healthy Living Centre. We call ourselves a community department store. We sometimes say we're the John Lewis of the social sector. We're owned by our community. Accessibility is all of what Bromley by Bow is about. You don't only come to Bromley by Bow when you've got a problem. You come to our beautiful cafe when you want to have a cup of tea. You sit in our park and read a book. You come with your children and play. You can do art. You can sing opera with the English National Opera or do theatre with the National Theatre. Or you can learn English, or you get free use of computers or free use of a telephone or welfare benefits advice or employment support and many other things besides. We're very welcoming. We know that centres like ours are successful by word of mouth, so we absolutely want our staff to give everybody a welcome, as you would expect in a good department store. And we have this wonderful range of services, and our staff are trained to cross-sell. You walk into a supermarket to Buster, and lo and behold, 4 hours later, you come out with more bags than you can practically carry of things you existed, let alone that you needed. Bromley by Bow, you come.
Dan, can you hear me? Or could it be the internet's? Let's give it a moment for him, for the internet to reconnect.
Coming for welfare benefits advice or to learn English, and in this infographic is the need for community agency. Communities need to be participants in their own futures, their own destinies. And this is really, really critical. This is the message from Bromley by Bow. It's about communities changing their own futures. So Bromley by Bow, a community hub, a medical practice, and a research team that I head up that sits inside Bromley by Bow, carrying out research and evaluation of our model all the time. I wanted to put this slide in. I put this slide in actually whilst others were talking. This is about the complexity of the social prescribing role. I won't go through the whole diagram there. This is a diagram developed by Caroline Frostick and Marcello Bertotti at the University of East London. And they did it through interviewing, I can't remember exactly, I think it was about 30 link workers to really understand the complexity of this. And I think in hearing people talk this evening, we need to understand whether we expect pharmacists to become social prescribing link workers, or we expect pharmacists to refer to social prescribing link workers. And at Bromley by Bow, what we've done is to embed the same referral forms that our GPs and nurses and healthcare assistants have in the consulting rooms in our health centres. And we've given those same referral forms to local pharmacies so that they can refer patients that they're seeing in the pharmacies to our link workers as well. And, you know, we know that good social prescribing involves a conversation with a patient, or at that point they're called a client, of probably anything up to an hour. Of course, it would be a rare pharmacist who has an hour in a pharmacy to be able to talk to a patient in depth about problems. So I think we need to be clear about maybe light touch signposting and maybe light touch referrals, but pharmacists are unlikely to have the kind of time that you need to be a social prescribing link worker. And they're unlikely to know the several hundred voluntary sector services that are available to people to access in the same way that a social prescribing link worker will know. This is the kind of sort of a diagram of the kind of networking that social prescribing link workers are part of within communities. And one of the features, of course, of their job roles is that they spend quite a considerable amount of time each week out and about networking with the third sector. We know that talking to social prescribing link workers, they really mainly feel confident about referring to organizations that they have physically visited and that they've physically spoken to the staff in those organizations who are the ones who are going to receive the referrals. And it's that level of confidence and that networking that social prescribing link workers do. They become part of an ecosystem within communities. And I think that's a really, really key function. And I'm not sure that pharmacists are going to have that time themselves to go out and about and to get to know the voluntary sector within their communities. It would be fantastic if they did, but I think we need to think about roles here. Yeah. This is a nicely provocative slide. This is rethinking primary, secondary, and tertiary care. Of course, pharmacy belongs to primary care in the traditional scheme of things. We would like to suggest that primary care is actually the individual, the choices they make. Secondary care is the individual plus close family and friends. Tertiary care is the below plus community. And of course, if all else fails, we've got the NHS. And therefore, that starts to get us to think where we need to invest and where the agency needs to lie. And we need to take agency out into the community, and we need to invest in communities. These are the kind of prescriptions you might get if you come to Bromley by Bow. So there's an intergenerational tea party bottom left in our beautiful 3-acre park. We have a community meal that was done by our time bank. So time banking is part of Bromley by Bow. A gardening group on the bottom left. An art class. We've got a social care program at Bromley by Bow, and we have our artists run our social care program. An egg and spoon race from that same intergenerational tea party. And there's our connection zone on top right, where you have free access of computers, free access of a telephone if you need to make phone calls as well. We've done a lot of research with our community over the last 3 years at Bromley by Bow, and we've created an outcomes framework based on what is meaningful to our community. And these are the outcomes that we are now starting to measure through a community-devised outcomes framework. And what our community is most interested in is co-production, contributing, being connected to others, being connected to place, building their skills and capabilities, and of course, having their basic needs met. And we know that for many, particularly in our more deprived communities, even things, you know, we have a food bank at Bromley by Bow now that is feeding about 1,000 families every week. So we know that even the basic things in the UK now seem quite precarious. You know, income, food, housing, you know, these are the really nitty-gritty issues that link workers are supporting people with every day. The principles of Bromley by Bow, owned and built by its community, it doesn't just meet needs, it also creates opportunity for people. We've been here for 35 years, and we will remain here for many, many more years. So being part of the fabric of a community is important. We believe in creativity and fun. Going to work in the morning at Bromley by Bow has to be about having fun. Having fun with your community is really important. It's about making things feel uplifting, and it's about destigmatizing. These are really important things as well. Connection is probably the most important thing that we're doing at Bromley by Bow. And the voluntary sector is fantastic at spanning boundaries, crossing silos, and at bringing lots of things together that don't normally this is a new health centre that Bromley by Bow runs. It's called St Andrews. It's got a pharmacy as part of it. You can see in the right-hand side. It's fantastic as far as it goes, but it's a very, very medical model. It doesn't have a whole community centre as part of it. But the next one, this is in Manchester, this is in Trafford. And we helped Limelight, which is a housing association, build the Limelight Centre. And it has a pharmacy as well. It has general practice, but it is also a beautiful community centre as well. And there's some wonderful integration going on in Limelight. And Limelight is very much like a latter-day Bromley by Bow, with pharmacy as part of the model. And it's got a community library. It's got a nursery there. It's got hairdressers. It's got a cafe. Many of the elements that Bromley by Bow has as well. So, and it also has about 90 extra care housing units for people who have long-term health care needs as well. So very, very interesting model. And that was inspired by Bromley by Bow, and we worked with them for several years on the ideas for Limelight. So we would suggest community ownership is really important. And one of the things we say to people is, you know, you can take up the agency. So one of the things that pharmacists can now do is really think about how they join forces with others within their communities. As Anne-Marie talked about, primary care networks create a brilliant opportunity for pharmacists to get involved with general practice, but also to get involved with community as well, and really sort of break down those barriers and become part of an ecosystem within their communities. And I think that's the last slide, yes. Great. So I'm going to stop sharing and hand back.
Well, thank you, Dan, for such an inspiring presentation. Like always, it's always like mind blown, literally. I'm pretty sure everyone watching here tonight was like knowing what is Bromley by Bow to saying Bromley by Bow is the future of healthcare for both health and well-being for patients. Thank you so much for being here tonight. And so yeah, for questions, let's keep it toward the end. We got a very strict schedule, but definitely when you mentioned about not having the pharmacist taking on the job of a link worker, I completely agree, because it's such a complex role. And as pharmacists, we're kind of time limited on what we can do. But also if I remember correctly, you do offer a training course for link worker, which is 28 days long, but you're also offering a shorter version, it's 5 days long. And I was kind of exploring the idea which coincide with Michael Holden's presentation on the Healthy Living Pharmacy, is that you have a Healthy Living HLP champion, but there's nothing stopping us to have a social prescribing champion or social champion, where you are like the work, your organization provide the very first UK qualification for social prescribing in the world. And you just give a quick word on this so our listener can get involved after, potentially to join the course afterward. So yeah.
Yes, and yes, so we do an accredited program that takes about 1 day a week for about 8 or 9 months. And then we have these shorter courses, and we're just actually writing a course on social prescribing for people who aren't link workers. And so this could be for pharmacists, it could be for people who work for, say, housing associations, it could be for people who work in children's centres. And it's taking the 5-day course for link workers and it's turning it into a course for people who aren't expecting to be a social prescribing link worker, but might do some signposting, but also might work very closely with link workers, so that they understand the concept of social prescribing, and they understand some of the key aspects of it, and they understand something around social determinants of health as well, but also a little bit about safeguarding, a little bit about confidentiality, all those sorts of things that they would need to carry out that role and work very closely with link workers. And we're just about to deliver that course in West Wales, starting in a couple of weeks' time. And we'd love to talk to others about how we might be able to provide that course to pharmacists. That would be fantastic, yeah.
Thank you, Dan. Thank you, Dan. And so now let's move on to our next speakers. Dawn Mitchell from Social Prescribing Youth Network. Very excited because the work she does is not just geared for senior citizens, but it's also for younger demographic, which we see quite commonly in the pharmacy. So Dawn Mitchell, I'll just hand it over to you so you can take the floor now.
Evening, everyone. Hi, it's great to be here. Thanks for having me. I'll just pop some slides up. So yeah, the main thing that we're going to share with you is the work. It's interesting following on from Dan, isn't it? Nothing like you know, trying to follow up on that. But I guess if Dan's the and Bromley by Bow have been leading the way for a number of, getting on for generations now. I guess the social prescribing youth network is really in its infancy, but starting to get some really good traction, and that's what we would like to share with you this evening. Please do follow us at spin_UK on Twitter, and I've actually just finished a Twitter chat live this evening, so if you use the hashtag CYP social prescribing, you'll see the amount of interaction that there has been this evening talking about this topic. So really excited to share some of our kind of headlines with you. So we've been we've been testing now. We got funded by the Department of Health and Social Care in 2017 to test social prescribing for children and young people. My colleague Paul Jarvis Beasley at Street Games, I don't know if he had a crystal ball or something. We certainly weren't aware of the kind of explosion that there was going to be in social prescribing, but we were, I think, out of the 34 programs that got funded through the wellbeing funding, I think we're the only one that focused on young people, and our chosen research area was around social prescribing. So the other name that you'll have heard already this evening is Marcello Bototti at the University of East London. He was our research partner, and they conducted a 2-year in-depth research piece around the work that we were doing. So link working for young people is relatively new. Traditional models are aimed at older adults and are aimed to take away, people with those non-clinical needs into community support. Actually, one of the things that we're finding is that it can be the opposite with young people, where young people actually need to be in touch with primary care, but don't tend to be until things get much worse, and maybe even present at secondary care rather than in primary. So there's a real opportunity here for young people to have better access to support and services. So we completed a research programme and with UEL and Marcello, and we had 4 local areas. We looked at Brighton and Hove, Southampton, Luton and Sheffield in England. And through this work, we kind of accidentally set up the Social Prescribing Youth Network, which we now affectionately call SPIN. We've got over 650 members registered as part of that SPIN sort of network now, and it just shows the level of interest really around this work. And we were also commissioned by NHS England and Improvement to run a consultation to ask people what they thought of a suggested framework for children and young people social prescribing. We had a huge response to that, and we pulled together all of the findings from that and fed it back to NHS England and Improvement. And we're expecting to hear more as we go into this year about future work in this area. So I was thinking about the opportunities that there may be for pharmacy in social prescribing for young people, and when I was chatting in terms of planning this talk, I think that the huge opportunity is that we know that young people don't just turn up at a GP or primary care. It's actually much more likely that they may access community services and may actually turn up asking pharmacists for advice or information about maybe sort of the drug therapy available for certain conditions, especially some of the more commonly seen ones, things like anxiety or depression. And actually there may be a real opportunity for pharmacists to not act as a link worker, but to maybe have good links to the local primary care network link workers who they can get young people in touch with. So the things that I thought about were holistic conversations and interactions with young people, lifestyle conversations as well as medication, good links with PCN link workers to support young people. And I guess you're the expert, so great to hear any ideas from you about different models, because what we are looking at doing is continuing to test different models of social prescribing for young people. It is a relatively new area. There was a review done about the evidence base, and that review found that there was no evidence, not even one paper. So I think we're the first to kind of publish in this area, which is exciting, but there's much more that we couldn't be doing. The key differences between youth social prescribing and adults tend to be the range of referral sources. So in our data, only 20% of referrals came from primary care or from a GP. The other points of referral included education, social care, schools, a really wide range of referrals. A lot actually came from friends and family saying, oh, I went and accessed this service, it was actually really helpful, and then sort of referring a friend. And then 10% of referrals came from an unexpected source, which was the police. And what we're hearing is actually that the police see social prescribing as a positive option for young people when potentially they might be looking at either going down a safeguarding route or a criminal justice route, or youth justice route, I should say. Youth working skills have been found to be paramount over social prescribing experience. We can kind of top up the social prescribing element, but really it's about having strong youth work, not necessarily qualified youth worker, but having youth working skills. And actually what we found was 4 out of our 5 link workers in the end ended up being a young person, kind of an older young person, so a young person who was maybe 24, 25, in the link worker role. And the young people found that really, really positive, because it was kind of more like a peer mentoring rather than a professional with a young person, because some of the stigma that surrounds accessing support, especially around mental health, that kind of reduced. And also if the link worker was taking them along to a session for the first time, whether that's sport or art or culture, that actually it was 2 young people turning up together, and there wasn't that really obvious kind of carer with a young person. So positive for lots of reasons. Activities and services need to be attractive and suitable. I suppose you could add safe onto that. So we need to check that the places that we're referring young people are the right and appropriate places to be going, and also that it's where the young people want to go and that it's things that they want to do. So an element of co-production is definitely really important there. Able to use social prescribing as a way to fill the gaps in provision. So we know that, well, to be honest, I don't think that there's any other word apart from decimated for young people's support services. A lot of universal services just don't exist anymore, and the main provision is very targeted. So we talk about social prescribing as being a way to create a safety net for young people and kind of fill, or at least, try and cover some of those gaps. Actually, the service in Southampton, the young people actually called it Mind the Gap, because they felt that they were falling through gaps in services, and that the link worker, because there wasn't any referral criteria, that link worker provided that support in where that gap existed previously. So I guess today is just really maybe about just raising awareness, just letting you know that this is a thing, that social prescribing for young people is happening. NHS England have spoken vocally about the fact that the funding for the link workers through the additional role reimbursement money does include an all-age service, so they should be or have the potential to commission social prescribing for children and young people. It's just about getting those messages out there. So I guess if you can advocate for that when you're having your conversations within your integrated care services as we go forward, then that would be fantastic. You can join the network for free, and I've put the link there. All of our research materials and all of our evidence, like the guidance for setting up services, everything that we've been able to find out is on there as well. And if you want some more heavy duty reading, Marcello's full, I think it's about 57-page report, is also on there as well. I'll share the slides so they can be shared afterwards. And hopefully I've just been able to share a little bit of insight and get people thinking about social prescribing for children and young people, because the other thing that's coming out of our research is the massive impact that it's having. And interestingly, the young people who benefited the most were the young people who reported the lowest levels of well-being at baseline. So we're really being able to have an effect with the young people who need it most. So hopefully that's been okay. I'll hand back over to you, Anna.
Thank you so much, Dawn, for your presentation. So everyone sharing some links that is part of the presentation from Dawn. So thank you so much for sharing your time here. I mean, the presentation you laid out is definitely new because, I mean, I realize social prescribing is quite a niche subject within the community pharmacy sector, or pharmacy in general. And then we can break it down. There is social prescribing, then there's also for the younger demographic, and people are like, so what's the difference? And through a presentation, we're able to highlight it. It is quite different. And then there's a way for you to get more knowledge, because when I first got involved with social prescribing, I immersed myself for like 3-4 weeks just watching videos, reading documents on social prescribing to get a better idea. So I urge everyone that's here tonight to definitely do some more research, because this conference tonight is definitely a snapshot of the full potential of social prescribing. So definitely get involved, join the social prescribing youth network like I did, and definitely do reach out to Dawn for any further question. Thank you so much for Dawn for your presentation. And so I would like to move on for our next presentation from Simon Sistarelli. So a bit of background. So myself, I'm a Dance for Parkinson practitioner. So it's a scheme that was created in 2004 in USA by Brooklyn Dance Center, for my memory, Mark Morris Dance Group, sorry. And my specialty, they did it from a ballet perspective. And I don't do ballet. I'm a street dancer. I do crump. And basically, I was trying to pioneer crump for Parkinson. But then I think it was 4 years back, I met Simone that's basically leading the way for popping for Parkinson's, which is a type of street dance. And he's done some phenomenal work. He's been involved with the Red Bull Academy. He's done a talk in Geneva through TED. He's doing education research on the effect of popping to benefit for health for patients with Parkinson's. So I'm very excited to have him here tonight, a fellow street dancer. Simon, the floor is for you.
Thank you very much. Thank you for having me here. It's great to hear all of this. This is so inspiring. I don't have any slides because I'm a dancer. And dancers don't usually work with slides, but I want to start here because it's been a very long evening already, but with so much information. And I just want to share this with you, just to give you an idea of what I do and the impact that an activity such as popping for Parkinson's can have, what kind of impact can have on people. So let me show you. Hopefully you're able to see the screen. So why did I share this video with you? Because can you believe that all of those people had Parkinson's? Watching this video, what you see, or what I see, is joy, is passion, is movement. Already, some of you already mentioned the idea of not treating the symptom or the disease. It's about the person. And this is exactly what Popping for Parkinson stands for. And that's what I'm trying to do with this project. Now, just a quick reflection on health. What does being healthy actually mean? And I want to take the case of Parkinson's. Parkinson's is neurodegenerative as a disease and has no cure to date. So when you get diagnosed, the question is, what now? What next? What can I do? It's all about learning how to deal with a disease. Unfortunately, pills can only do so much. And again, they treat the symptom. But what about everything else? This is not a competition, though. This is not about dancing instead of taking pills. It's about understanding that we need the full 360 picture of who we have in front of us. The evidence is clear that movement is key to achieve a healthy and balanced lifestyle. And this is valid for everyone, so much so that during the lockdown, we were still able to exercise outdoors. This is where it gets interesting. What kind of movement? A recent publication from the World Health Organization, Dr. Frankfurt, she did an amazing job. They highlighted that out of all the movement activities, the ones that were artistic were the most impactful and successful. In other words, the impact of movement-based artistic activities on people's health is remarkable. And the same publication actually goes to highlight Dance for Parkinson's as a perfect example of that. Now, you might wonder, how come? How come we prescribe dance classes to people with Parkinson's? It sounds insane sometimes, and yet it makes so much sense. There's so many factors that make dance a powerful tool and really unique tool. But just looking quickly at the three obvious levels of the physical level, the psychological, and the social. On a physical level, dance is intrinsically a form of physical activity, and it's based on balance, weight shifting, coordination, rhythm, timing, awareness of self in space. There's so much, fall prevention, so much more. So obviously when you practice the physical, you have physical benefits. On a psychological level, dance has a huge impact on students. This is what I think is the area that has the most impact and has the least amount of research, unfortunately. Dance helps with mood, quality of life. It reduces depression and anger. It boosts self-esteem. And for some, this could be quite intuitive. But what is fundamental to understand is dance allows you to be an artistic, expressive being. And when it comes to people with Parkinson's, their bodies go from being decaying cages to channels of expression. Now, this shift in perspective is fundamental because it allows participants to feel like they're taking back control of their own body and therefore of their own life. Ultimately, people feel empowered again, and it also allows people to delve deep into the process of acceptance of self, and even, including the disease in the picture. On a social level, dance brings people together. That's it. And now with COVID, if we learned something, is that dance really has that power, and we miss socializing. And dance has a great tool to socialize. It increases the social connection, so in terms of quantity and quality, which is incredibly important. Dance does not care who you are, where you come from, your background. It welcomes you, it embraces you, If anything, differences are celebrated rather than discriminated against. In hip-hop specifically, in hip-hop culture and dance, if you look like someone else, it's kind of frowned upon. It's a no-no. So that opens up a huge potential. This is why I strongly believe that everyone can dance and everyone should dance. Dance teaches you essential life skills and basic human values that are clearly lacking in today's society, and that we're full of racism and injustices and negativity. Again, COVID highlighted this more than ever before. And when it comes to interventions, dance has one of the lowest dropout rates because participants actually enjoy it. Now, they have a desire to keep practicing, which is actually, this is not an aspect that can be disregarded, because consistency in participation is key to achieving long-lasting results. And that is valid for everything and everyone. A person that is diagnosed with Parkinson's has a fundamental choice to make. There's two possibilities. You can either be a patient as a slave of a disease, or be patient in the process of acceptance. Dance allows people not to feel trapped by the disease and to bring humanity where it got lost. Dance remixes the concept of disability, because as you saw in the video, what is Parkinson's? What is dance? Does it even matter? What do you see? The changing perspective is what is needed. And it's exactly that, taking everything as an opportunity, as a starting point, turning negative into positive. Of course, it's not always easy, but it's definitely simple and clear. And I want to talk about the impact that this change of perspective has, because it's so big, it's still to this day, after years that I've been doing this, it still feels magical. One of my students from New York, actually from that class, once wrote to me saying, I feel like these popping dance classes are helping me to get back control over my body and help me find the body control that I lost due to Parkinson's. Not to mention the wows I get from my grandkids when they see me dance. Now, this effect might not be measurable by some scales, but the effect of this is remarkable. And while we talk about impact, Parkinson's severely affects people's lives on so many levels. Parkinson's can change the way you walk, the way you talk, the way you dress, your behavior, your self-esteem, circle of family and friends around you. I wanted to remix that concept and substitute from the word Parkinson's the word hip-hop. Hip-hop can change the way you walk, the way you talk, the way you speak, your behavior, your self-esteem, circle of family and friends. And this is the kind of impact that I, as a dance artist, wanted to bring to the community. The same impact that hip-hop gave me, the same strength and power that hip-hop had on me as a kid. To conclude this, I heard some great things tonight, and I really hope that this is the starting point for collaboration rather than competition. Understanding that everyone, at the end of the day, what we all want is for the people that we have in front of us to be better, feel better, whatever that means. And what we can do as practitioners, if you wish, we can offer our skill sets and our time to listen and offer value to these people. Again, as I said at the beginning, it's not about, oh, let's get people to dance and not take pills. It's about understanding that we need everything together at the same time. What is also really important for me is to highlight the importance of a centralized network. Why do I say this? I really hope that tonight will be the first of many meetings and encounters and network opportunities, because as it was highlighted before, it's not that straightforward yet to have a central point of information for everyone, both patients and people outside this that might not know anything about it, as well as for practitioners. You know, I discovered so many things, so many great individuals and opportunities tonight that I was not aware of, even though I am in the social prescribing world, and I have been for quite some time. So what I think is very much fundamental is to create some sort of centralized hub or platform, let's put it that way, so that we can all share information, share data, and hopefully at the end of the day, make people's lives, including ours, better. Because I don't know about you, but for me, it's a win-win situation. I do what I love. I share my mission, my values, and my passion with the people around me. They benefit from it. It's a win-win situation. It's a no-brainer for me. And I'm sure that you are on the same page too. Thank you very much.
Thank you, Simon. I'm totally speechless. I just like when you were playing the video, just growing with the beat out of unconscious being a dancer myself. So thank you so much for such a powerful presentation. You definitely provided a clear insight for non-dancers on how that magical moment where Parkinson patients become dancers right in front of it, because that was my powerful narrative 4 years back when I was being a volunteer for a class offered by Ballet for Life. The class was called Moving to Wellbeing in London. And that's what was such a powerful desire for me to bring social prescribing to the pharmacy world, that I'm a dancer. I've seen what dance can do to Parkinson patient. Let's take social prescribing more seriously, including our everyday practice. And hopefully it's easier to see than just see word. And the video was like it. If one picture is 1,000 words, a video is 1,000 pictures, right? So thank you so much, Simon. Definitely let's keep in touch. And definitely people do connect with Simon, inspiring guy. He's done some phenomenal work. And so yeah, we got a very tight schedule. So let's move on to our next speakers. Xavier Schneider from France, a fellow pharmacist, very good friend of mine. We've known each other for 3 years. And he's got some very powerful presentation, because in France, the term social prescribing is not that well known. So me and him was kind of brainstorming name together, making les prescriptions sociales. And so yeah, Xavier.
Okay, good evening, everyone. Donc I share my screen. Okay, now. Alors. Okay, it's okay for you?
C'est bon, Xavier, tu peux aller.
Ok. Hop. Voilà, okay. So, alors, we are two friends and two pharmacists, two authors, and one mission promote pharmacy social prescribing. Oops. Voilà. Alors, my background, I'm a community pharmacist since 2005 in Trüstersheim, a charming Alsatian village in France, in a health hub as a K-hub. I have a degree in therapeutic patient education and degree in orthopedics, practical multidisciplinary teaching of e-health, and a degree in leadership meditation and neurosciences. I have 3 passions, multidisciplinary care plan, effective use of digital health, and promotion of all aspects of preventive health. And I'm a member of association, co-founder of RPS-PSN, Réseau des prescriptions sociales et prescriptions en santé numérique, or Digital Health and Social Prescribing Network. I'm a committee spokesperson of Pharmacy Services Valorization, CVAO, and General Secretary of e-Health Society, le Conseil de la e-santé. Alors, you know what is the definition of social prescribing with wider determinants of health. In France, there are no real definition for social prescribing. Nevertheless, Professor Nino and the CPS team defined the NPA as a non-pharmacological interventions are science-based and non-invasive intervention on human health. They aim to prevent, care, or cure health problems. They may consist in products, methods, programs, or services whose contents are known by users. They are linked to biological or psychological processes identified in clinical studies. They have a measurable impact on health, quality of life, behavioral, and socioeconomic markers. Their implementation requires relational, communicational, and ethical skills. Professor Nino describes 5 categories of NPI. Donc, the first is psychological, art therapies, health education programs, psychotherapies, mind-body programs, and animal-assisted therapies. Second, it's physical, exercise programs, horticultural therapies, physiotherapies, manual therapies, and balneological programs. Then nutritional, dietary supplementation, nutritional programs. Then digital, MLs, healthcare video games, and virtual reality therapies. And the last, it's the more classical, elemental, with product minerals, mycologicals, botanicals, electromagneticals, and cosmeceuticals. In these areas, the pharmacist can identify, signpost, advise, document, follow-up, and support. Alors, since 2016, we have exercise on prescription. The French government gives 100 € for 8 sessions of exercise with a coach, sport coach. Donc the place of pharmacist is above all in the recruitment of new patients in the general population and give patient to prescriptor. Alors for pharmacists, we have a number of experimentation, PharmUp study. The background is in combination with diet level of physical activity practiced involved in the development of chronic diseases, increase the usual level of physical activity and limit sedentary lifestyle. In the general population, it's a real public health issue. The objective is pharma studies aims to assess the role of the community pharmacist in promoting a regular physical activity practice in patients with chronic diseases in order to change behavior in the long term. With different partners, DGS, SFMS, EpiConcept, Sport Santé Conseil. Methods. PharmUps was introduced into 11 community pharmacy spread throughout France. Initially, 604 patients, adults and holders of prescriptions for chronic diseases are included in the study. Patients are divided equally into a control group and an intervention group. The pharmacist provided to the intervention group a kit containing information on follow-up book with recommendation, a pedometer, and a list of local physical or sports activities offered, and also practical and dietary advices. Levels of activity, sedentary lifestyle, and quality of life were assessed through questionnaires at baseline and at 12 months at the end of the study. Alors, the PharmUps programs, je vois qu'il là-bas. One moment. Okay. Alors, all the program it's in the box, same as medicines, with guide and the pedometer. Voilà. There are different educational tools for motivational speak and written. The study results. Only 150 patients completed the study until the 12th month. At the end of the study, the exposed group increased significantly level of physical activity by 50%. The time spent sitting or lying reduced significantly by more than 11%. The TV viewing time significantly reduced by around 20%. And the physical conditions of the exposed group was significantly improved during the year, and the trend toward improved mental condition is observed. In the control group, no significant improvement is observed on different parameters. In conclusion, patients have significantly improved their physical practical level, limited sedentary behaviors, and improved their quality of life. The involvement of pharmacists in project to change behaviors related to health should be considered as a tool to educate, inform the public, and promote regular physical activity in the fight against chronic diseases. And furthermore, actually, we develop a program, Pharma et moi, for community gamification, challenge, and rewards. And Bouge, or Move, for connecting with health trainers for exercise and prescriptions. And it's okay for me. Thank you, Aaron.
Thank you so much, Zoe, for your presentation. I really appreciate it because, you know, like you have, like the health system in France is different to UK, and you're able to bridge a gap between, you know, like social prescribing is in UK, NPS is in France, and you kind of laid it in such a way that it makes it easier to understand and definitely open up for partnership, collaborative work between France and UK. So, and I think I was able to link up Professor Nino with Gareth Presh, potentially to have further discussion. But thank you so much for Xavier. If anyone got any question, feel free to ask him toward the end of the conference. And so yeah, this one we got Denis Silva, very powerful person around the world of digital health. If my memory serves right, she's top 10 in the world for digital health, and she is representing Basel Strategy and VR for Health. And she was kind enough as well to do an interview for my book. So thank you so much, Denise. And so yeah, I'll let you introduce yourself, Denise.
Well, thank you very much. I have found this evening extremely inspiring. It's been a long time that I have admired all that pharmacists can do, and we certainly are seeing it now in this COVID period even more. So I'm not a dancer, I'm not a pharmacist, I'm not a healthcare professional. And I'm really here to speak about one of the non-pharmacological interventions that has really captured my interest. I went into the area of digital health over 20 years ago to promote it, because I thought it was going to be the universe that could rectify a lot of things that were missing in healthcare, of spreading information and improving quality, because we could measure what we could do. And it's really been taking a very long time. And I very much admire what you are doing, which is mostly not particularly digital and extremely effective. So we need everything in this world. And I'm an American in France, not a French person who mastered English. So I'm going to talk to you about the therapeutic uses of virtual reality, which I think will have a good future and potential for pharmacists. But today it's just going to be an introduction to what this is, because most people are not very much aware of it, even if they've tried out a, let's say, an Oculus headset. So I'm going to share my screen. Yeah. So let me just, yeah. Are you seeing this well? Yeah.
Yes, I can see it.
So virtual reality really was able to take off with the invention of the Oculus being independent of the computer. There still are headsets that require being connected to the computer, and it's much more complicated to use them. And so you will find a lot of videos with information about virtual reality as a therapy on vrforhealth.com. That is a platform that we started just a few months ago for the purpose of educating and informing, and everything is accessible on there. So virtual reality, you can't really experience it unless you are in the headset. Nonetheless, you can take my word for it, that if you were to see this program, for example, you would really, why is this not? Yeah, you would really feel like you are up there. You would be moving your head around and you would have a 360 view. And those hands could become your hands, those feet could become your feet. You would just really feel it. And if you discuss with therapists, they will tell you how effective this is. And in fact, this program is done by a British company, Oxford VR, that came out of Oxford. So, for example, somebody who was afraid of going on heights in a shopping center, after 3 sessions was able to go there. And there had been many studies reported that with VR, in a total of 2 hours in 5 sessions, you can accomplish what would have taken several months. This has been expressed over and over again by psychologists who use this. So more effective, faster than face-to-face with a therapist. Why? Because the therapist cannot produce the conditions. Even if you talk about it, even if you try to imagine it, he cannot produce the conditions that you can see. So it's really like therapy on wheels, and for all sorts of fears. Now, with something like this, you wouldn't want the person to be off by themselves, having to expose themselves to things that really frighten them. But in the presence of the psychologist, whether in their office or at a distance, it does work. I'm not aware of experiments done with pharmacists, but I don't see why that couldn't be done. Many people confuse virtual reality and think of it just as a game. So I wanted to show you that even when it looks like a game, it can be therapeutic, because in this case, the person can be doing physical rehabilitation by using the controller with their hand. There's the eye-hand coordination. There is rehabilitation of the eye. It could be of the brain after a stroke. It could be after a fracture for an arm, a leg. It makes it possible to do things without being bored and therefore to really do them. Whereas if somebody asks you, go and do this movement 100 times, you're not going to be able to count, you're not going to be able to do it. And with virtual reality, we know exactly what happens. So here's another example. You saw the dancing for the Parkinson's. This can be done with a person in the universe. There's also a lot of this being done with trauma for the military, for example, putting them really in the environment. Burn victims. So this is extremely powerful with respect to pain. And this man is going to talk about his situation.
I was really anxious from the trauma of the initial pain when it happened, and then after, when I went down there and they knew what happened, then I tried the VR, and instantly it was so much better. I was able to take like an Ativan, and basically they had to give me a little bit of anti-anxiety drugs, and then just my regular painkillers, and I was able to sit and go through it very easily. Right? It totally took down the stress and the anxiety of going through it. Also, it went by really fast, right? You could feel it, right? Like I could feel them pulling and things like that, but it's as soon as I could feel a little bit of pain, I just draw my attention back to the VR, where they kind of guided me through that too. So that really helped, yeah.
So I also wanted to talk about pain in labor for the growing number of women who would like to avoid anesthesia. Virtual reality can be used, and I'm going to show you a woman who in the United States, actually since that particular recording, she had yet another birth. So 2 of her 3 children were born using virtual reality.
And I used the apparatus for probably about 2 hours, and I really did not feel that I worked for 2 hours. I felt like it was only like a half hour, and during that time, like my my doctor came over to take the apparatus off me. I'm like, what are you doing? He's like, you're ready. Like, you're going to push your baby out. And within less than a minute, I delivered my baby. And one of the things that I was so surprised about was when I delivered her, immediately I was able to connect with her. I breastfed immediately. There was none of that. Like, she wasn't drugged. So I had a very successful experience using VR.
And for those people who would worry that perhaps the older set might not be able to do this, there is in fact a company that works a lot on reviving positive memories for the older people, making them feel like they are back. This could be people who have a beginning of dementia, but they feel like you can put them back into their original, into a universe that they remember, that will speak to them. And that's what's being done here. So I wanted to mention this because when you and I look at something like this, which we saw earlier, you might say, well, I don't see how that can really keep me from feeling pain or bring anything to me. It's because we don't fully understand how our brain works, but when you're in this three-dimensional environment and you really believe that you were there, so this is different from augmented reality where it's a layer on top of your regular world. Even something like this that might be even considered a bit cartoonish by you, it can have a tremendously soothing impact on you. And there are companies developing libraries of choice that people can go towards the colors and the kinds of things that they like. So if this was of interest to you, you might want to tune in on March 31st. So that would be 6 p.m. GMT. You can sign up through our website for this free webinar during which I'm going to be discussing with a patient who has had serious pain for many years and who uses, not exclusively, but who uses virtual reality. And he is such an engaging person that he's in California. He is an advisor to the Department of Defense. He's a former veteran for their own research. He's an advisor to various organizations for clinical research. So I'm looking forward to speaking with him on March 31st and taking questions. Of course, the main question here is how can pharmacists get involved? And I think the first thing is to figure it out for yourselves, to in some way borrow or use a headset, check out some of the very basic meditation kind of programs that there are. The best known, one of the best known is TRIP, T-R-I-P-P, that is recommended by many, and see how you feel about it and what circumstances you could do this in. I mean, if it, Arun was saying that certain pharmacies that would have an extra room could have a headset. I'm talking post-COVID, could have, because that room is probably being used for vaccinations, but one could imagine some sort of situation where people could come in regularly and be relaxed through what you do. And I think that things are going pretty fast in this area because of all the mental health issues that are rising. There's just a ton of material on PubMed to read, and there are many articles and, as I said, videos on our website, vrforhealth.com. And I hope that this was of some interest to you. If there are any comments, I'd love to take them.
So thank you so much, Jenny, for your presentation. Definitely opened up a perspective for pharmacists, because there's so much potential with digital health, and virtual reality therapy is one of them. And definitely one of the ways that I can see being integrated is to try to tackle social isolation. So yes, you do have social prescribing, you do have the connection with the link worker, but then offering virtual reality provide an additional part of ecosystem to help complement the improvement in health and well-being for the patient.
Yes, I know a psychologist who was also a school psychologist, and this can be used for people who have social anxiety, because we were talking very recently, and there's an article on the site we were talking very recently about the flip side of COVID. For a lot of people, the fact that there is this restricted lifestyle, semi-lockdown kind of situation, it's a positive. And when we go back to regular life, if we do, I hope we do, these people will no longer be in the norm. Like staying at home and doing everything by themselves has become the norm, and they feel free and relaxed. And so virtual reality could have a role to play in bringing them back, back in society.
Thank you, Dennis. First of all, thank you
so much, Arun, for such an open mind and inviting me, this non-British, non-healthcare professional who doesn't do social prescribing.
I always, like for me, I'm the kind of person that always think about vertical learning. So I say learning from different industry and how you can come together to provide a new way of doing things, isn't it? And you're able to provide that element. So thank you so much for sharing tonight. So I know we were supposed to finish at 9:45 and then go for networking lounge, but lots of people are in their flow state, deliver powerful content. But there's two people that was meant to give a presentation, but they couldn't make it due to other commitment. So I have two more videos. One is from Dr. Anant Jani from the University of Oxford, which has a segue from your Oxford paper. And then after that, it'll be finally the vice president of FIP, which is the International Pharmaceutical Federation, which represents 4 million pharmacists globally. And he represents the community pharmacy section, which is representing 3 million pharmacists globally. So I'm going to leave this at the very end. So I'm going to play Dr. Anant Jani's video, which toward the end has a very interesting link. And then after the two videos, we can go on for questions. Or if people want to head to a networking lounge, that's fun as well. So, but everything is recorded. So yeah, let me share my screen. Je vais commencer. C'est getting my wife to give me a hand. C'est ça? Ouais. Can anyone see my screen? Oh, j'ai déjà pris. Yeah, thank you, thank you. So, PSPC, Janine. Comment on fait un grand écran comme ça? C'est ça, hein?
Yeah. Hi, my name is Anant, and I'm a research fellow at the University of Oxford. And today I'm going to talk about some of the work that we've been doing at the University of Oxford on social prescribing in collaboration with the RCGP, the Royal College of General Practitioners, and sponsored by NHS England. And I'm going to specifically focus on the role that community pharmacy can play in social prescribing. So what we're seeing so far is that COVID-19, the pandemic, has been devastating. And we know that the aftermath is probably going to be equally as devastating on multiple dimensions that basically affect all aspects of society, whether that be education or jobs, food security, substance abuse, domestic violence. We're also seeing mental health issues cropping up all over the place. And these social issues cannot be solved through a medicalization or a medical lens because they are fundamentally non-medical in nature. And this is where I think many people believe that social prescribing can play an extremely important role in trying to address some of these needs. And what role can and should community pharmacy play within social prescribing in this broader context of trying to tackle some of these issues that we're going to be seeing over the year stemming from COVID-19. Last year, we had this piece published in Pharmacy Magazine, exploring the role that community pharmacy could play in social prescribing. And we highlight three key assets of community pharmacy and community pharmacists that could play a huge role in social prescribing. Number one is knowledge, knowledge about the system, knowledge about communities. Number two is relationships. Again, relationships with primary care, secondary care, social care, and also, very importantly, the community. And thirdly is infrastructure, There's around 11,000 pharmacies dotted across the country, and there's tens of thousands of community pharmacists. So from that perspective, community pharmacy can play an extremely important role in actually supporting social prescribing. And what we've been doing at the University of Oxford is utilizing something called the RCGP Research and Surveillance Center, which is a sentinel network of 1,800 GP practices distributed across England and which are nationally representative. And these GP practices upload their EHRs twice a week. And then that data is pseudonymized and made available for public good purposes. So we've created, for example, a workload observatory, COVID-19 observatories, etc. And using that data, we have created the Social Prescribing Observatory, which is updated on a weekly basis and demonstrates social prescribing activity across all ICSs within England, and disaggregated by different attributes like age, gender, IMD, ethnicity. Here is the link to the Social Prescribing Observatory, which you can go to and play around with on your own. Everything is open source. And what we found so far is that from Jan to September 2020, there have been over 250,000 social prescribing referrals across England. So on this heat map, these geographical boundaries indicate the different ICSs, and the numbers within the ICSs represent the rates per 10,000 of social prescribing. Digging down a little bit deeper into that data, we looked at IMD and ethnicity, and these bars represent rates per 10,000. The error bars represent the variation across the different ICSs. And what we basically find is that for IMD, the index of multiple deprivation, and ethnicity, there's no difference between the different subgroups, really. We found no significant differences, and we also didn't find any significant differences for gender either. We did, however, find a significant difference for social prescribing for different age groups. The 65 plus demographic gets more social prescribing than any of the other age groups. And the 0 to 17s hardly get any social prescriptions at all. Now, coming back to the, I guess, starting point of this brief talk, what role should community pharmacy take? Well, again, because community pharmacy has this close relationship with all of the key elements of the system, including the communities and patients, they can play a critical role in trying to coordinate and harness community assets in the form of the VCSE organizations, delivering different services for social need, and ensuring that there's seamless coordination, because that's something that is not happening in a consistent manner across England, because some groups know about all of the community and voluntary sector organizations available, some don't. Some have an idea of what community services are available, some do not. And given community pharmacy's role within the system and the fact that it coordinates across so many different actors and is able to do so seamlessly, I think this presents a great opportunity for community pharmacy and community pharmacists to take a more proactive role in social prescribing and utilizing the knowledge, relationships, and infrastructure that has developed over the years and basically applying it to social prescribing as well. I'm sorry I can't be with you today, but I'd be very happy to explore areas of synergy and collaboration, so please do feel free to email me.
So, comment je réduis le truc? I finish with the video. How do I exit it? My window is on. Okay. So that was Miss Dr. Ananjani, a presentation from the University of Oxford. I do encourage you to message him and do check out the link to kind of get a map, hot map of what's happening in UK. So now I'm going to finish off with the last presentation from Dara Connolly, and this presentation will be based on the 4 pillars of community pharmacy, because they've created a document for all 3 million community pharmacists around the globe. And I highly recommend, if you're not fine with FIP, to join the organization and download the vision strategy. I'm going to play his video of the Vice President himself of the Community Pharmacy section.
Good evening, colleagues. My name is Dara Connolly, and I'm a community pharmacist from Ireland. And I'm also the Vice Chair of the Community Pharmacy section of the International Pharmacists Federation, FIP. I'm delighted that Arun has asked me to say a few words this evening around social prescribing and the role of the community pharmacist, because it coordinates very nicely with our current vision for community pharmacy within the FIP, called Vision 2025, Pharmacists at the Heart of Their Community. Community pharmacists are a unique and independent profession. Healthcare and how it is delivered now has never achieved more for the communities that we as pharmacists serve, or you as healthcare professionals also serve. Across the globe, people have never lived longer and enjoyed better healthcare than they do today. As we look back through the history of pharmacy, we can see that community pharmacists have always sought to improve their profession and to adapt to the needs of the people they serve and the communities they serve through their professional practice, and also being attuned and responsive to their individual patients and broader communities' needs. We have done so by always identifying ourselves as a unique profession with a unique and relevant skill set. There exists throughout the globe a fantastic and unique infrastructure of community pharmacies, and we are the experts in optimal outcomes for prescribed medicines, and therefore the cornerstone for effective provision of universal healthcare. Through our vision for the practice of community pharmacy to give greater value and greater outcomes for the communities that we serve, we have identified 4 pillars of practice of community pharmacists that do not exist in isolation, but exist to complement each other, where pharmacists can work to the full scope of their practice with these 4 pillars. We are able in our communities to give best outcomes to our patients, to deliver more efficient healthcare, and also to increase our communities' access to that healthcare through the infrastructure of community pharmacies that already exists. Those 4 pillars are that pharmacists in their professional capacity prescribe, dispense, administer, and review. So it's best to think of these 4 competencies as being complementary, and they are circular rather than linear, and that they interact with each other in 1s and 2s and 3s and 4s. What is most relevant to the discussion that we are having this evening is the capacity for pharmacists to prescribe. So we're to start with the definition of what prescribing is. It's the iterative process involving information gathering, clinical decision-making, communication and evaluation, which results in the initiation, continuation or cessation of a medicine. Pharmacists prescribe medicines for people in their pharmacies who present with common ailments. Notable advances in pharmacist prescribing include greater access to hormonal contraception and emergency contraception, therapies for urinary tract infections, upper respiratory tract infections, and minor ailments, and travel medicine through pharmacist triage, screening, and prescribing. Within the spirit of our vision, when we look to see how we can do more and offer more value for the communities and the patients we serve, there is a fantastic opportunity to align with the prescribing that we give a definition to here of medicines, to also to extend that prescribing to social prescribing. If we consider that the pharmacist in their community pharmacy is the most accessible and most often visited healthcare professional that somebody has in their community of care, the opportunity for social prescribing by pharmacists is fantastic, because not only do we know the communities we live in and the surrounds that those people live in, we also know the people, we know their families, and oftentimes, as I will in my community pharmacy, I can be looking after 3 or 4 generations of a single family. And I am seen as that point of contact, as that trusted advisor. It also gives an opportunity that when a pharmacist can administer, a pharmacist can review, and a pharmacist can dispense, that by using those 4 pillars together, we give a holistic care to the patient as it is needed. And we have an opportunity to be able to prescribe better by reviewing better. And we also have an opportunity then to be relevant to those people that we serve. This is not to say that pharmacists will be the only healthcare profession who can prescribe socially, but what we would look to do is to be an integral part of that healthcare team that makes social prescribing work and makes social prescribing relevant. This is an exciting time for the practice of pharmacy in our communities because so many things have changed through the unfortunate COVID-19 pandemic. We have seen people's access to healthcare professionals change, but also the way people interact with their healthcare professionals change too. Every healthcare professional is aware that we are going to practice our own professions differently into the future because of the COVID pandemic. And it gives us great opportunity to change, and it gives us great opportunity to embrace change. I am very confident that social prescribing will become a cornerstone of better health outcomes for the people we serve and the communities that we serve. And I am sure that it will be embraced fully and wholeheartedly by community pharmacists around the world. Arona, I want to congratulate you for putting together this meeting this evening and to driving forward pharmacists in social prescribing. Have a very good evening and a successful conference. Thank you.
Thank you, everyone. So how do I exit getting help from wife again? How did that? Okay. And then how do I stop sharing? Is stop share, right? Is this well? No. Stop share. Okay. So we're coming to the end of the conference. So I mean, for question, it's quite late in the evening. So if people got time for questions, if speakers, you need to go, that's fine, I'll completely get it. But first of all, thank you so much for everyone for being here tonight, for supporting my vision, for being there to support pharmacy with social prescribing. And but if you do need to go, I completely understand because it's a long day. But if you got opportunity to answer a question from delegate for those that managed to stay for the whole event, then thank you, Lauren, for your comments. But yeah, I mean, any question, if people's in the code, that's completely fine. There's 5 of us. There's me, Denise, Marianne, Sam, Aripes, and Xavier. And thank you, Denise. But if you got any question, you can ask them now. Or if you want, there is a networking lounge. It's quite cool. You should definitely give it a hand. It's more like similar to what we're doing, but more like an informal setting. So if you want, we can have a more informal conversation there between speakers and panelists. But if you got any question to finish off the conference, that's your time. Or maybe any other comments from panelists on how you found tonight's session. Anything you want to sum up? Anything like finishing statement, closing sentence? Anyone? No? Okay. So I'll probably draw it an end to this conference. Thank you so much for everyone. Thank you for Denise, Xavier, Harry, and Dr. Maria and Sam for staying here. So for delegate, you can either join us at the lounge. I'll be there for the next half an hour. But for those that want to go to sleep because you're working early in the morning, I completely get it. So thank you all so much. And thank you, Nira Sani, for your feedback. Thank you, everyone. Have a very nice evening. And for those that wants to go to bed, have a very good night. And for those that want to talk some more, because you've been inspired for tonight's session, let's meet up in the networking lounge. Yeah. Thank you, everyone. And so, yeah, thank you.
Thank you very much. Thanks.
Thank you. Thank you. Thank you, Harry. Thank you. So, Sherry, how do I end it? Just asking how to end it. and meeting for Allah.